Anybody can find a niche to work with Africa CDC. 3 is easy access to critical information by establishing continental framework for data sharing. Again, here it is extremely important. Yes, I'm presenting the mandate of Africa CDC, but really I think that it is extremely important that we talk about data exchange, data sharing. So we have, this is the operational model. We have 5 regional coordination centers, one for each region of this continent. You have in green, in Central Africa, Charity start home because I'm also the acting coordinator for Central Africa RCC, so that's why I'm pointing the Central first. In Gabon, we have for Southern Africa in Lusaka, East Africa in Kenya, here where we are, West Africa in Nigeria, North Africa, we are yet to get nomination. So there is no country that is hosting the RCC in North Africa. Okay, in terms of cooperation with member states, we are dedicating necessary resources to building partnership to improve effectiveness of our operations. And also we continue to develop partnership with member states, ministries in charge of health, and agencies dealing with disease control and prevention, which will always serve as national contact point, like the National Public Health Institute in member states, and above all, alongside the One Health approach. And we are empowered to work with all the sectoral ministries in the member state, not only with the ministries of health. And that is the value addition of Africa CDC and its comparative advantage. And Africa CDC is the only single health institution that is technical, but sitting right in the medical, in the middle of political environment. So it gives us really wings to fly high. And for the data, again, I'm coming back on the data exchange and the sharing. Africa CDC may be requested by member state, regional economic communities, commission, and others to provide scientific or technical assistance in any field within its competence. So to do so, we need data. And if there is no data, we can't provide assistance, to provide scientific or technical assistance when it is required by the policy. Like for instance, during the COVID-19, in the midst of the pandemic, the director of Africa CDC, the former director of Africa CDC, briefed member states more than 20 times, head of states and governments. So if there is no data, how are you going to brief them? Extremely important. So whatever we are doing, we need to feel part of this. So there is need to build a robust and put in place sustainable mechanism that enable accurate sharing of data to inform decision making and action. The work with WHO, also Africa CDC follows the established clear procedure for cooperation with WHO. We have signed MOUs with WHO, and also Africa CDC and WHO will always develop a clear framework for collaboration. We have already one, but the work we are doing is very dynamic. So we need time to sit down and look at it, revise it when need arises. So Africa CDC and WHO depend on cooperation of member states to implement programs, particularly in data exchange, the same way member states have entrusted WHO. Africa CDC is a credible and a tailored, go faster response to solve African problems, right? And you heard Dr. Ahmed this morning mentioning the new public health order, and our work is guided around the new public health order today with these 5 core areas. One is strengthen public health institutions from really the national level till the continental level. Extremely important. We need to strengthen our institutions. We need to expand the local manufacturing in terms of vaccines, therapeutics, and diagnostics. Today, we are only producing 1% of the vaccines that we need for the continent. We need to scale up. And we cannot ensure our health security. Same for the other countermeasures. So we need really to scale up that one. We need to strengthen the public health workforce. We need, according to WHO, if you take the ratio 1 epidemiologist for 200,000 inhabitants, we are far away for a continent of about 1.3 billion inhabitants. So that is important action-oriented and respectful partnership. We want a partnership that is action-oriented and a partnership that respects our needs. We don't want a partnership that will come and impose on us that this is your priority. Nobody can come from outside and tell me that your house is not clean, clean it. I know better my house than anybody else, right? Increase domestic resources for health. We know that what is coming from outside is not predictable nor sustainable. So it is good that we put our resources down. CDC will continue to control their destiny with this kind of cooperation with member states. So the key challenges experienced by Africa CDC to operationalize its mandate, you know, the low awareness of Africa CDC mandate among member states. That's why this presentation is extremely important. And we will do it repeatedly during the future forums that we will have with our member states so that they understand the mandate of Africa CDC. Lack of trust by member states to share data. Your data is safe with Africa CDC, so don't be shy in sharing the information with us. Competing priority by Africa CDC to meet demands from member states, like many requests from low investment in health system by member state. Okay, the Abuja Declaration. We know that in 2001, head of state and government have decided to allocate at least 50% of the annual national budget to health. How many countries have met this commitment today? Barely 6. Barely 6. So we need to revisit. Out of 55 member states, only 6 have met this commitment. And it is, you know, year after year, one country will pull out, another one will come in, 15%. It is not consistent. It is not the 6 countries, you know, consistently. You have, if you analyze for the last 10 years, you have different countries every year, you know, different countries. So there is no consistency. So this is something that we need really to address as well. The low investment, we talk about it. And of course, the high attrition rate of the workforce on the continent outside, that is something that we need also to address. In conclusion, member states and Africa CDC need to draft and adopt a data sharing agreement. That is very important. We need to plan a regional advocacy to share data exchange agreement, right? The data sharing agreement with member states in all 5 regions. And we need really, member states need to invest in local capacity, especially on the workforce. And Africa CDC is encouraging member states to invest more in the institution by demonstrating impact with the current investment. So these are the few words that I have for you. Very soon in the morning, this morning. So yes, thank you very much for your kind attention.
Great. Thank you, Dr. Benjamin, for that comprehensive presentation on the Africa CDC mandate. So as you remember, the establishment of Africa CDC was accelerated by the Ebola outbreak in West and Central Africa. The thinking has been before that, but I think our launching in January 2017 was accelerated because of the Ebola outbreak, the necessity to have a continental coordinating body, a health agency that really rallies countries together to deal with emergencies in a coordinated fashion. And then our initial establishment was as a specialized technical institution within the Union. We used to report to one of the departments at African Union. But later, the decision was made that we are an autonomous health agency of the Union. So that reporting structure and the whole function of Africa CDC changed, including the mandate to declare public health emergency of continental concern. So which is really a significant change in terms of the way Africa CDC operates. So thank you really for describing that one very, very well. So the next one is that we'll listen to country experiences. Yesterday in some of the presentations, it was mentioned that some countries have started already implementing the event-based surveillance in a coordinated manner, and we'll listen to some of those countries. So the first one will be to listen to the experience of implementation of EBS from Kenya, our host nation. So I would like to call upon the presenter, Dr. Negeri from Kenya, to present for us. Thank you.
Yeah, thank you so much for that. Philip Ngere once again is my name. I'm the EBS focal person for Kenya. And from onset, I want to state that we owe our story to the great support that we get from the ministry and the government, led by director seated here. We owe our story to Africa CDC. I'm happy Mercy is in the house. I'm happy Ahmed is in the house. We owe our story to the US CDC, and I'm very excited that Arun is with us here. That is where it started all. And I'm also excited that our country office is represented. Dr. Penina Monyo is also in the house. And we owe our story to the many partners, WHO, and the local stakeholders that we work with. I will share our experience, and mine is simple. Just to take responsibility for the omissions and the commissions in the presentation. Otherwise, the successes belong somewhere else. So I'll speak around the coordination mechanisms that we have for EBS in the country. I'll speak around the strategies that we've embraced in the process of implementing this surveillance system. I'll also speak to the monitoring mechanisms, including the event management system that we have for EBS in the country. I'll speak again around a bit of the successes. There might not be many, and the challenges that we've faced, and finally, what are our thoughts moving forward. For those of us who might not be aware, Kenya, we have a devolved system of governance. We have the national government and subnational levels of governance, including 47 county governments. And largely, our healthcare system is modeled around these governance structures. So when we speak to the implementation process, we'll be talking about counties, sub-counties, the national level, and really that makes reference or gets modeled around that governance systems. In our implementation, again, we've adopted a multi-sectoral and a multidisciplinary approach in the sense that we work with various sectors, including health. Health is just one of them. And we also work with various groups, government agencies, partners, the community, and the private sector. So if you look at, I'm not too sure this pointer works, but if you look at the projected diagram or figure, you'll get to note that we have the animal health sector, we have the environmental health sector, we have the Ministry of Health sector, the human health, and of course there's a zoonotic disease interface between the environmental, human health, and animal health sectors. And we have the partners, and all these come together to form a national stakeholder forum for EBS. And this also functions as the technical working group for the implementation of EBS in the country. Largely, this is work in progress, in the sense that part of this is a dream, part of this is a journey that we're already walking. And besides the national level, we have the sub-national level. If you go through our technical guideline, you'll realize that we also have proposed to have the stakeholder coordinating agency at that sub-national level. So between the two levels, then we have the Council of Governors. This is the team through which we work with to coordinate communications between the national and the sub-national levels of governance. In terms of strategy, the objective of EBS in the country largely is to complement the routine surveillance system that has largely been indicator-based. And by roping in EBS, then we hope that we strengthen the early warning systems, including widening the scope of conditions under surveillance, and providing, improving the detection rates, considering that we take these surveillance systems right to the doorstep of the communities where things happen. And therefore, in terms of the delivery of this system, we've come up with strategies. One of the strategies is to make it an integral component of the surveillance system. So from onset, we decided that we are not going to put in place a parallel surveillance system when it comes to EBS. We made it part and parcel of the routine surveillance system. We defined our EBS guided by the framework of Africa CDC 2018, and we are really looking forward to the one we are launching today to help us see what do we need to tweak in our strategy so that we align ourselves to the documents that we launched today. And I'm happy this came out from the previous speaker before me. He said whatever comes from outside is never sustainable, and it's barely enough. Yeah. So for us to try and make the implementation sustainable, we ride on existing structures. That means that when we come along to implement EBS in any region, then other than the initial cost of the training, there are no additional resources that we come along with. We'll ride on the existing structures. So we have community health systems that we ride on. We have veterinary service delivery systems that we ride on. We have the administrative structures that we ride on. We have the education system that we ride on. We have a lot of community networks that we ride on without necessarily having to invest in new structures. We adopt a One Health approach just like you saw in the previous slide. And one of the revolutions that I think have made our EBS, be the way it is now, is the digitization of the whole process. Our EBS is paperless, right from data capture, data sharing or reporting, the visualizations and even the analytics and the visualizations are automated. That through some dashboards we're able to see what is happening, and the community members are able to report to us without necessarily having to fill some hard copy documents and bring them on board. The coordination through that technical working group that I showed earlier has also been a good strategy for us, in the sense that we try as much as possible to make sure that everybody is onboarded in the process. The implementation is scalable, and I think this speaks to most of us, in the sense that it is scalable by site. We don't have to start the entire country at the same time. We can start in a small region and onboard additional regions as we move on. It is also scalable by type, so that we're able to start with one type of EBS and monitor the way it is working and bring on board the other types as we move forward. And lastly, it is also scalable by the signals that we use in detecting these public health threats. We have 9 routine signals that we use, and when we initiate EBS, we don't necessarily have to bring on board all the 9 signals. We can start with a few, then introduce others as we move on. And this has also worked well for us during outbreaks, in the sense that whenever we have threats, we're able to quickly define signals that we can use for those specific threats that we are going through. I want to look at our milestones in 3 categories. One is a journey that we have all walked, all of us in this room, by virtue of being Afro member states. We've been implementing IDSR, and this IDSR has given us a big, platform for us to be able to, initiate EBS processes. But the other thing that has happened is the establishment of the hotline. Remember, we have hotline EBS, and for Kenya, hotlines began much earlier. Our first hotlines were actually put in place in 2010, the year 2010. Then they were not structured, but we had lines through which the public could engage the ministry. They were managed at the national level. Then came 2016, with the support of WHO, we were able to put up a national EOC. But when COVID struck, with support of CDC, we were able to, put up subnational, EOCs, and this really were supporting the response towards COVID. And when doing EBS, then these are major platforms that we can ride on. But back to mainstream EBS, the initial trainings began in March 2019. And this was largely with the support of Africa CDC. With Dr. Ahmed here, we were with Mercy. We had to go to Turkana, the farthest end towards the north. We had to go to Wajir, the northeastern part. These are the remotest part of the country. And this is where we did our initial trainings. Then subsequently, we had significant support from the US CDC to evaluate what we were doing. And when we did this evaluation, then they came up with an implementation plan of what we are currently doing. And this implementation plan involved, region by region introduction of EBS, initially, and of course going type by type. And as we speak now, I think we've reached 6 subnational regions out of the 47 that we have. So this expansion is largely work in progress. and strides. In 2022, we were lucky, we got the support to develop country documents, because we realized that rolling out EBS without the guiding documents was not easy. So we came together, got the technical support, and developed the technical guidelines. We developed the training curriculum, and we have a number of IEC materials that we are using for the training. So as we speak now, we are rolling out the 3rd edition of the technical guideline, IDSR, and EBS is firmly grounded in the document. I said we have an event management system, and just to walk us through monitoring systems that would get to pick through this. We have the data capturing and reporting tools for every step of the EBS process. So in our system, we have signal detection tools, we have triage tools, up to response escalation tools. We have indicators that we track routinely, and of course, we have monitoring platform, including taking advantage of the social media, not social media, but virtual platform that have become popular, lately. Our event-based surveillance, event management system for the EBS has dashboards, including in-app dashboards and web-based dashboards that we use for. Like I said earlier, one of the things that has really revolutionized our EBS system is the digitization of the process, and we have a mobile-based app that we use for all these processes, data capture, reporting, and even monitoring. This mobile app is built for us, so it is something that actually built around the healthcare system for the country. It is available on Play Store. It's freely downloadable, but for you to use it, then we need to add you into the system. Even for iOS users, you can use a URL that is available. Then you'll be able to download it, and or even use it from your laptop. It is interoperable with other systems, so means through use of APKs, data can be shared between DHIS2 and the app, and plus other surveillance platforms that we use within the country. It also has an inbuilt in-app dashboard that from the comfort of your seat, wherever you are, you're able to monitor what is going on and provide the needed support should there be. Some of probably the numbers as we conclude, as we speak, we've not been able to onboard many. We've only done 6 counties out of 47, and these counties have community health units that help us in implementing community health, community event-based surveillance systems, and we've only onboarded like 10%. For the health facility EBS, we've onboarded, I think, like 0.5% of the health facilities that we have in the country. So largely, this journey is just beginning. We still have a long way to go, but we're optimistic that together we will make it. So on the processes, if you look at the processes, through this system, we've been able to, through the community event-based surveillance, we've been able to detect up to 85, high risk, very high risk events, which for us probably would have gone unnoticed. We are working well in terms of the processes. We've set a threshold of 80% for every step. The only challenge that we have, as you can see there, is the transitioning from signals to events, the verification process. We find that we pick a lot of signals which don't translate into a near equal number of events, probably because of the sensitivity of the system. And the same image, repeats itself in health facility event-based surveillance, where the transition is not optimal for us. Some of the enablers, digitization, of course, I've already talked about that. We know that digitizing the system is efficient, is timely, and reduces cost of handling data. Yeah? And I think that's one of the things that we count on as having assisted us in doing what we've been able to do so far. Development of the documents, of course, without the guidelines, we don't know how you engage others and even how you conduct business. The rider programs, Kenya has a very robust community health systems, and we simply ride on this to implement community event-based surveillance. We also have the healthcare systems networks of a number of facilities. We have the EOCs in the country, and we just ride on these structures to make things happen, including the animal health systems. Whenever we do the trainings, we do both human, animal health, and environmental health teams. National level of advocacy, I think this for us is a miracle that happened. I'm sorry, I have to say this in the presence of my director. We've been able to have EBS as one of the performance contract indicators for a cabinet secretary. How it happened, I don't know. Maybe he has an answer for that. But because of that, then we are pushed to make things happen. Because every quarter, he has to ask, we purpose to do this, where are we? And I think that is also one of the things that make us moving forward. We have dedicated partners, US CDC, Africa CDC, WHO, and many other local agencies. And we usually have technical support, technical reviews, and of course, financial support from these teams. Achievements that we've had so far, prompt detection. If you listen to the clip that has been played here before, in the areas where we've done EBS, they've improved their performance when it comes to AFP detection rates. This is because the community is now sensitized. We have the signal tracking AFP, and they're able to report on them. And as far as detecting some of these conditions, things have happened fairly well. The other thing that has happened here is that now we have even animal health diseases being reported by community health volunteers that previously had interests only on human health, and vice versa. Improved detection of outbreaks, things that we would have missed before are now being detected, and I think that is an achievement we can talk about. Surveillance in fragile situations, we've seen this happens. Yesterday, we were informed here that as Kenyans, we were exercising our democratic rights. So this exercising of democratic rights sometimes also present with some fragile situations. We've seen in our previous elections, the counties where we have implementing EBS have used this to report issues of internal displacements, issues of conflict, issues of insecurities, and these have public health tags, and I think works well for us. I said early, in COVID, we were able to come up with COVID-19 specific signals that we used to enhance surveillance. In EVD, just the recent EVD scare, we were also able to develop EVD specific signals that we are using to enhance surveillance for EVD. And as we speak now, there's MABAG, and what we are discussing is coming up with MABAG specific signals to unload into the system to help us enhance surveillance for MABAG. Strong community-based surveillance system, I think already spoken to that. And of course, One Health approach, we work very closely with our, the other stakeholders in the One Health space. And this has improved a lot with the implementation of EBS. Challenges, some challenges though, weak ownership. At the national level, we pride of a very strong ownership led by the cabinet secretary. But remember that we have the devolved units, and therefore there's still bits of challenges in trying to have them follow suit and help us in this journey. Little stakeholders involvement, a number of stakeholders are present, doing some bits and pieces of event-based surveillance, but for a long time, we didn't have a guideline to help us put people together. As I speak now, moving forward, we have a guideline that each one of us in the EBS space then have to come together and walk the journey together. Weak linkages with the lab systems and of course the routine surveillance systems. As you are aware, EBS largely is about events. It's about these threats that are not necessarily confirmed by lab. And therefore, when we respond and pick samples, sometimes it becomes a challenge in trying to track what signals translated to what events and finally became what public health threats of interest. I've already spoken to the low event signal ratio, and probably this could be something about our sensitivity or the sensitivity of the signals that we need to think through. And the manual phone-based or hotline EBS and media scanning EBS that we are currently implementing. And we are happy that EIOS in the country is work in progress. Soon we'll be onboarded and we'll be able to automate the system. I'm also happy to report that, maybe let the cat out of the bag. Dr. Munywa, maybe you forgive me. But we're also working on automating the hotlines. Yeah? If this works, then maybe in our next meeting we'll be talking about an automated or rather a virtual call center that you're able to have in your phone and walk around with. So as I conclude, advocacy, advocacy, advocacy is the message, whether you're doing advocacy for partners to come on board, advocacy for funding, advocacy for data sharing. Advocacy, I think, is the way to go. Strengthening stakeholders coordination is important. Integrations and linkages with lab systems and IBS systems. Improve monitoring, focusing on evaluation. We need to be continuously evaluating, and the acting director for Africa CDC emphasized this. We need to be able to measure what we are doing, get to be guided by whatever it is that is happening, so that we're able to improve. We need to consider exchange programs. Kenya, as we speak today, is not a member of the community of practices supported by Africa CDC. I think it's high time we were also onboarded, so that we can also, have exchange programs with other member states, so that we get to know, learn from them, we get an opportunity to share whatever it is that we are doing together as a continent or as a region. Of course, technology is with us here. Whatever it is that we are doing, we need to think technology. We need to think how do we, digitize our systems, integrate them. So in conclusion, in Kenya, what we've seen that is event-based surveillance is effective in complementing IBS for a strong early warning system. When you have EBS in place, your early warning system becomes very strong. And a lot of opportunities still exist. And it's up to us to take advantage of these opportunities to improve the systems that we are trying to implement. As a human being, it is natural. You are born, whatever life steps you go through, you don't forget your mother. So we thank Africa CDC so much for initiating this talk, this journey with us. We thank the US CDC, including our country office, for holding our hands and walking the talk with us. And I think the bit that we've been able to do as we speak now is largely due to them. WHO is our grandmother in the surveillance platform. And of course, the other local agencies that we work with, we really appreciate the support that we've received so far. Thank you so much.
Thank you very much, Dr. Niere. So I think we really saw a very strong program in Kenya. I really picked, some 4 things that we can learn. One is, they considered a multi-sectoral approach in terms of coordinating implementation of EBS, which has been really, the recommendation and the calls that everybody has been making since yesterday. And then they also consider EBS in integration with the existing surveillance program, the indicator-based survey. So implementing EBS as an adjunct strategy with the existing surveillance program. And then they have really, tried hard to digitalize data collection process. It's an electronic data collection tool. They are trying to extend it up to the community level so that, there will not be this, delay in terms of relaying the information, because we said, this is an early warning system. And then finally, it was really, encouraging to see, the progress in implementing EBS has been monitored at higher level by considering EBS as a key performance indicator even the cabinet secretary can look into. I think that's a big achievement. So thank you again, the Kenya team, for your wonderful experience, and I hope other countries will also learn from this. So the next one is that there is an attempt from Africa CDC to push the implementation of event management system, an electronic tool to capture the event, relay the information, and will also allow you to produce a summary report for action. And that was started as an internal tool for the Africa CDC to monitor events across the continent. And later, we engaged some member states, and they are taking advantage of that one. And there's really, an experience from some of the countries in domesticating or adopting that tool. So I would like to invite you, to see, a short video in terms of the process that we went through on implementing event management system. Is that ready?
Africa CDC has an enormous role in the development of event-based surveillance in Zambia.
We, as Uganda Ministry of Health, the Emergency Operations Center particularly, we have really benefited from Africa CDC's efforts in event-based surveillance, giving us the framework and training us. Before 2022, Uganda was conducting event-based surveillance activities very well, but with the little knowledge that we had, we did not have any training, no framework, so we just hit and run. You say, okay, event-based surveillance, and then we start. Then came 2022 when we had formal engagement with the African Union, particularly Africa CDC. This is when we reached out to the head of the EBS unit in Addis, and she accepted to come over and train us formally on how to conduct event-based surveillance in the country.
Using the EBS as some of the documents we've used to adapt our work towards implementation of event-based surveillance in the country. We are now at a stage where we've developed the guidelines for Zambia. And Africa CDC has been very, very prominent in the offering technical support in the development of the same guide for Zambia.
During that workshop, we had what we call the event management system demonstrated to us. And we said, oh, on part of our EBS activities, I think we need that system. Then Africa CDC was happy to say, can we talk? Can we develop a concept? Can we see who is the player? Then we identified the players, okay? In the Ministry of Health, we had to have the Division of Health Information come in. We also had to have some programmers, that HISP Uganda and HISP South Africa. They came over and they started developing the system for us.
The event management system was it's an initiative that we've embraced so well. With support from Africa CDC, we've now trained all the 116 districts in the country and all the 116 districts now are able to use the EMS system for purposes of reporting the issues of generating reports, assessing risk, and also response. So all the documentation as it relates to management of events from signal detection to response is anchored on the system, and most of the districts are participating in the system.
Health security globally is not complete until every part of this world is safe from outbreaks and disease threats.
There is a framework which Africa CDC has, and they trained us on how to do a hotline EBS, facilitate EBS, facilitate best EBS, how to undertake call center, everything. And then we also had a chance to adopt the material we got from Africa CDC into Ugandan.
In the short period in which the EMS has been deployed in the country, we've seen quite a number of signals and events being posted on the system. COVID-19 has been one of the conditions that has been shared on the system. But other than COVID, we see that we are sharing a lot of information pertaining to vaccine-preventable diseases. In particular, it's the measles events. We've reported quite a number of chickenpox as well. Scabies have been picked up through the same system, but other than these skin conditions, we've seen it going beyond to report issues around bilharzia as some of the events that we are picking up.
The EMS in Uganda is still work in progress though, but we are so excited about what we have already achieved. The EMS has captured so many signals because at the level from community to the triage section where there's a lot of noise. We have levels in Uganda where we do the verification. For example, at national level, I will not go to a district, say Obonji or Kagadi, and I confirm an outbreak. No, there are structures already at the grassroots. There is what we call a district surveillance focal person. Even lower health sub-districts, there are several surveillance focal people. So as we receive it from the national level here, we'll triage it to them and they will confirm. We cannot say as Uganda that we are there yet. We still have some challenges, especially having the programming done to completion. Our event management system is still work in progress. We are still working on it together with our programmers from South Africa and Uganda, plus the local Ministry of Health Division of Health Information. The
implementation of EMS currently is anchored within the Ministry of Health, but our wish is that it needs to have an output of One Health surveillance, in the sense that the priority list of signals are not only related to human health, but cut across other sectors to do with animal health, environmental health, and the ecology. So we need partners on board to be part of the process. Other than that, you need huge investment in terms of the information, communication, and technology tools in terms of computers which needs to be deployed for our staff for use. The other aspect is obviously around interoperability of the systems, because the EMS system alone needs to communicate, for example, with epidemic intelligence from open sources. It needs to communicate with the Public Health Emergency Operations Center. So those are some of the challenges we have, but with the support from partners, we should be able to overcome those challenges and make the system even better within the country. Yeah.
Africa is willing, able, and ready to do its part. We are asking you, as our partners, to join us in implementing the new public health order so that we can be able to do things differently, to be able to achieve different and better results.
So, great. That's, the experience from few countries, and I think next time when we gather, so we hope all of us will have a story to tell. So this is just a start, and thank you very much. So the next one is to really listen to a success story from Zambia, and you have seen it in the video part of it, but to really get in depth in terms of how Zambia went through in deploying the event-based surveillance and the event-based event management system. So I would like to call upon Dr. Swamba to tell us the Zambia story.
Yeah, thank you. Good morning, everyone. My name is Simbaba Devi. I'm a public health specialist coordinating IDSR as well as event-based surveillance based at Zambia National Public Health Institute in Zambia. I serve under the Disease Surveillance and Intelligence Cluster. And with me here, I have the person who leads the cluster, who is Dr. Kapina, our director. So I'll run through our presentation, just sharing what event-based surveillance implementation has been for Zambia. So in the case for Zambia, in 2017, through the joint external evaluation, highlighted a lot of gaps, and the gaps that were highlighted were in relation to real-time surveillance. And within that, you could see that we were in yellow in areas around indicator-based surveillance, event-based surveillance, the aspect around EMS, interoperability, and the aspect around syndromic surveillance. So we made a conscious decision to see how we bridge the gap and start addressing those gaps specifically in relation to surveillance, which is event-based surveillance, which I'll more or less talk about and also touch around the aspect of event management system. So within Zambia, we are organized in such a manner that event-based surveillance is done at national level, it's done at the district level and community level. Within the national level, we have a media scanning platform, which is anchored within the Disease and Surveillance Intelligence Cluster. We also have the hotline or the call center, which is anchored within the Community Research and Information Cluster. So the two platforms are helping us implement event-based surveillance. But what is key is that the media scanning is the one that has matured relatively well, and we've transitioned from using automated manual manipulation into semi-manipulation. Now we are in an automated system using the EIOS. Other than that, I think it's important that we highlight the aspect of event-based surveillance at health facilities, which is relatively weak, but the one which we have really supported is that of community EBS. And within that, we are piloting the aspect of the mHealth, which is a DHIS2 instance for purposes of reporting. So all these platforms need to converge into the data management system, which is the EMS, which I'll also share in terms of what are some of the products coming from that platform. We have a catalog of staff that is helping us, of course, led by our director, but those are the key people who have been assigned to perform the function of EBS at different levels. But what is highlighted in red, which is multi-sectoral teams, I think that's an area that Zambia needs to improve so that we can implement EBS across a multi-sectoral teams. So our journey really began in 2018 in Cairo, where Zambia was part of the member states that were invited to launch the EBS framework. From this journey, we came back to doing our own situation analysis using the SWOT analysis approach. We also deployed tools to measure our capacity in terms of EBS. Arising from that, we had developed a roadmap for implementation of EBS and identifying partners and budget lines which we needed to support the process. So we have incorporated event-based surveillance into the national technical working group, and within that technical group, we have various partners who have participated in identifying some of the gaps and given us technical support, and Africa CDC is one of the partners there. Again, with support from Africa CDC, we embarked on training of trainers, and I'm glad that one of our colleagues here, Dr. Ahmed, was one of the key facilitators from Africa CDC that took us through the Africa CDC framework, which we adopted. And within the workshop, we identified our priority list of public health signals that are relevant to Zambia. And we also generated a clear flow of information as it regards to EBS. After that, we started developing our own guidelines. There was a need to develop our own guidelines using the Africa CDC, and the draft guide was validated with partners, a lot of partners participating from Africa CDC, WHO, the UK Health Security, and many others. So we also validated our standard operating procedures for the media scanning, the call center, the health facility EBS, as well as the community EBS, and a new roadmap was developed to chart and support the EBS implementation. So as earlier shared by Macy, we are now at a stage that we have our own guidelines, and these guidelines were reviewed and updated with support from Africa CDC. A key to this guideline now has incorporated the elements of M&D to monitor the progress that we are making through the program. So as indicated, we have established the call center, but it needs to increase its scope in terms of functions from what it used to be focusing on as COVID, but we need to increase the scope. We are also, like I did mention, media scanning has been automated now with the use of epidemic intelligence from open sources. We received support in terms of training from WHO. I'm now at a stage where I can say that out of the 116 districts, 49 districts have been trained. Among them, around 1,000 healthcare workers and 2,820 volunteers. Those are health volunteers. In our country, we are also trying to introduce some innovative approaches to implementing EBS. So far, we've piloted the DHIS2 instance in terms of implementing community EBS, and this is at evaluation stage. I'm happy to report that through support of East Central Southern Africa Health Community, we've been supported to upgrade the system so that it can become more versatile and feed into the EMS. Again, with support from EXA, we have adopted the Africa CDC that is training manual. A draft has been crafted, and now we are at a stage of moving forward to the stage where we build on the works so that we can validate the training manual. Again, these are some materials that came from Africa CDC. So that was the workshop that was supported by EXA with technical support from our colleagues under Africa CDC. Like I did mention, with support from WHO, our media scanning now is automated. We are using the epidemic intelligence from open sources, and we had a training where multi-sectoral teams were convened and they participated in the training. So we have now a focal point person who is spearheading this aspect of our EBS, and now the next stage is to move from where we are to creation of boards which can be categorized into the One Health approach as animal health, ecology as some of the players, so that they can participate fully in the system. Currently, we only have animal health, human health sector which is participating, but our wish is to extend it to our colleagues through creation of boards, and that is work in process. The other aspect is obviously to link the system to the EMS instance. so that we can also at national level input into the system, and that is work in progress, and we've been in conversation with Africa CDC to work on this gap. Again, in terms of building our real-time surveillance, we also received support from Africa CDC. We adopted the event management system, and within that, Zambia has been trained. We identified our priority list of public health signals and events, which were agreed and updated. The training of trainers were done, and now we've developed a work plan for rollout. Currently, we have all our districts, 116 districts trained, but we are at a stage of improving it to go to the sub-district level where our health facilities, the key ones, can also be trained. The other aspect I can talk about is about regional practice in terms of EBS. We are part of the team or member state that participated in the epidemic intelligence training. And within the training, we obviously received the capacity in our media scanning. We also formed the regional community of practice, which has worked well through the WhatsApp. But our desire is to transition to physical meetings. But key to this is that this platform has allowed us to share key information around health security. And through this platform, we're able to share weekly CDC reports which affect us as a region. Like I did indicate, we've trained 116 districts, and we've also trained all the provinces, the 10 provinces across the country. We've replicated the community of practice at all levels, and within that, we've also integrated it into our national and provincial surveillance meetings for purposes of tracking our performance as it relates to EBS, specifically also to EMS. So in terms of the output from the system, we are proud that we are able now to generate weekly event surveillance reports. And within that, we can also see some of the examples of reports that are coming from a rural remote district highlighting their COVID situation. So this has improved in the manner in which we've been capturing events, as seen in the next slide. So this is more or less the output indicators from the system. In just 3 months of training, we have seen 452 entries. The numbers of which were complete were 304. Numbers of signals were 22, and events 255. We've seen that the majority of the events and signals we are seeing are related to human health, but we still have some zoonotic conditions reported at 23 events and 3 signals. The other area of improvement when we look at this slide is obviously the aspect around picking signals, which speak more to EBS, and this really is to address the fundamentals of training more people in EBS, which has been the gap, and that is what we are trying to advocate for, so that we can pick more signals, because this is where EBS lies. So this is just to highlight some of the conditions we've picked up from the system, like measles. We've increased the detection. We've seen that even under cholera, we've managed to improve our detection, but within this slide, we can see that districts that have been trained in EBS have managed to pick the condition early and also curtail the disease quite quickly as compared to other ones. But this is work that we are still evaluating. In terms of mumps, we've seen an increase in detection of mumps through the system. And also Zambia is responding to polio in the region, and this is just the aspect of surveillance around polio. So our challenges really are that we have this system EMS developed, but there's need to train more people. I'm happy that through the materials we've launched today, there's a section that speaks to the EMS, and that should be addressed in due course. Then we have the system, but we really need to incorporate some of the 7.1 indicators and make it interoperable with the other systems like the electronic EDS and the FEOC. We, as Zambia have, as I did mention, we have the guidelines. We've trained 49 of the 160 districts, so we really need to bridge this gap so that that slide we are assured that we have very few signals being picked can now start picking, because EBS is for early detection, and the elements around signal picking and verifying is very, very key. So in conclusion, as Zambia, we've seen that our real-time surveillance has improved over time using the state party annual report assessment. And the key to that, we are seeing that the EMS has increased the detection of events. And our core is to see that we sustain the gains that we have at the moment and also increase usage at all levels through continued government support and partners. So these are the stakeholders that have been supporting us through this journey, and this is where we end as Zambia. Thank you so much.
Thank you, Dr. Suwamba. Very good work again in Zambia, trying to expand event-based surveillance to more districts, training more districts, having an automated media scanning for epidemic intelligence for open source. And they have engaged veterinary, but are looking to engage other sectors like environment. And then they are also expanding the implementation of EBS into community-based EBS. So good progress again. So I'm rushing you with series of presentations because I think we were a little bit late because of that launching event. So bear with me, and if you have some questions, maybe just keep them towards the end of the session. If you have some time, we will entertain at the end of all the presentations. And presentations are also quite related. These are country experience, and it may apply to some of your questions may apply to all countries. So now I will move into the next presentation, which is on the impact of event-based surveillance community of practice as a mechanism to facilitate health information exchange. Soa Bogatev from Tunisia will be walking us through that presentation. Thank you.
Thank you very much. It is a pleasure for me to present our experience in the community of practice in North Africa. I am Soa Bogatev, medical doctor, head of health surveillance in the National Observatory of New and Emerging Diseases, Tunisia. So I will start with a brief rappel of the EBS implementation in Tunisia. So first we create 24 epidemiological units in all, one unit in each regions with a focal point in EBS. We do also some trainings for the different member of epidemiological unit. So a rapid response team, many training in a rapid response team in collaboration with GHD and AFNet. We do also the implementation of field epidemiology training with AFNet. We have now 4 courses in intermediate level, 2 courses in front line. We do also training in Lab EPI in collaboration with GIZ. It is a collaboration with laboratories and epidemiology at regional level. Also, we start since 2016 with EPITech. It is epidemiological conference telephonic to exchange information in surveillance through the 24 region. Since 2020 and with the pandemic of COVID, we start with EPICOV. It is a conference, a video conference with the 24 region. We elaborate also guidelines and SOPs in EBS, we do training. We elaborate first a curriculum in eWars, early warning and response system, and it's hosted in the Medical University of Tunis. And this year we will have our first cohort in eWars. All training was done with One Health approach. So we have health sectors and animal sectors, and all level, national, regional, and local level. We elaborate also our digital tools. It's a platform, informatic platform in EBS, specific platform in EBS. And since 2021, we start in collaboration with EMRO to use EOS, epidemic intelligence of open sources. And this year we will start with community-based surveillance in 6 pilot regions. Okay, so this is our EOS, using EOS with our Tunisia team since 2021. We do training, we elaborate our sources and diseases. And we have now a permanent team who work daily in the EOS with the daily report and weekly report. Okay. So this is our digital tool in event-based surveillance. It is a specific tool elaborated with the IT team in Tunisia. It is part of integrate platform who integrate for networking, networking in emergency, a private sector, specific networking in early system of West Nile virus, and also event-based surveillance. So now we will integrate this platform to the EOS. So we have to, we can notify, do the triage, verification, and risk assessment, and finally put the action plan in the platform. This is our epidemiological epidemic team who work daily in the EOS. This is the weekly report on EOS. I am sorry, it did not work. I don't know what happened. Okay, and this is our bulletin. It's a monthly bulletin, epidemiological international bulletin on all events occurred in Tunis and in international level. And we can find this bulletin in the site of observatory, onmne.tn. So our community of practice represented for different member states of North Africa in charge of EBS epidemiological surveillance, with also focal points of Africa CDC. And now we have 29 members, participants in this community of practice. The objective is to share information about all events through regular virtual meetings, to share best practices, including around the event management system, experiences, challenges, and how they were resolved. share operational tools and resource plans, strategic plans, work plans, definitions, etc., to establish a networking of experts to bank on the skill and knowledge and resources plan exchange, and also to create an e-learning platform for EBS. We participate first in a meeting who held in Tunis in July 2022. It's the coordinated event-based surveillance regional advocacy workshop carried on by the Africa CDC. So during this meeting, it was an opportunity to share information about all events through a regular virtual meeting, to discuss the experiences of each country in the implementation of EBS, to adopt the Africa CDC EBS framework with One Health approach, to build skills in event-based surveillance. So since that date, and in coordination with Africa CDC, an EBS North Africa community of practice has been established with regular meeting every 2 weeks and sharing information in the context of epidemiological surveillance. Sorry. Okay. No. Next one. The community of practice was facilitated the rapid verification of information on possible cases of example for hemorrhagic cases. It is a rumor in Libya. So we contacted the focal point in Libya, and we have the just information in real time. Also, we share a regular exchange of event information, resources. For example, Morocco share a plan on monkeypox, Libya and Mauritania share plan on measles, and Tunisia share plan on West Nile virus and also on event of Shigella. Oh. So a skills transfer, if a country develops documents, specific response plan, protocols, and so on, so other countries can take advantage of existing plans and adapt them to their context, which save a lot of time. Also, we share experiences and challenges and how they were resolved. Tunisia will be very proud and honored to provide assistance and share our experiences, including West Nile, monkeypox, EOS experiences, and others with other countries for North Africa and other countries in Africa. So success stories for the community of practice North Africa. The setup of the community of practice in North Africa, and now we try to involve more participants for this community in different sectors, animals and environmental sector. Communicate and exchange information in real time between the countries in North Africa. We have a key focal point of a member state identified and mandated by their country, and who can communicate all relevant information without restriction of confidentiality. We have a meeting regularly, even if there is no emergency or epidemic, and there is the opportunity to exchange experiences. So the challenges, diversity of EBS capacity across the region. Countries are not at the same level of the implementation of EBS, but it is utopian to have all the countries at the same level, so we have to move forward together and to learn for each other. The regularity and punctuality of the conference are important. We must keep them even if we have nothing to communicate. And the sustainability, so we don't have only one focal point for each country, but we have a team, and then we can do the turnover and to maintain this activity. So last, the recommendation, I think, yes. Virtual conference is good, but it is not enough. So we have to do a face-to-face meeting. Training are needed to maintain this sustainability at least 2 or 3 times per year. Commitment of member states, each focal point must have officially identified as an advocated with decision makers. The adoption of Africa CDC framework on health information exchange with institutionalize the North Africa EBS community of practice. Recommendation also to support the establishment of cross-pollination initiative for knowledge transfer, and to have some exchange visits between member states and other organizations too. This will ensure a buy-in for EBS at a high level. And last recommendation, I think, is to have our EBS learning, I think. Oh. Yes, platform, so that member states doesn't have to learn from a scratch by waiting to be supported. And thank you very much. Thank you.
Thank you. Yeah. Thanks. So, thank you, Dr. Soa. Very good experience again. The application of community of practice for easy access in terms of information in a region, how things are going on, and they were sharing some outbreaks, information about some outbreaks across different countries participating in that community of practice. So our last speaker this morning will be Joshua from Uganda to tell us your experience on implementing event-based surveillance in One Health approach. So Joshua, you are standing between the participants and lunch, so I hope you will be very brief. Thank you.
I promise I will be very brief. Thank you very much for the opportunity given to me to share some of the experiences that we have from Uganda. My name is Joshua Kayua. I am in the Ministry of Health, and with me is the Director of the National Institute of Public Health. Forgive me. I work in the Emergency Operations Center. I'm standing between you and the lunch, so I'll be a little fast. Sorry about that. This is how our EBS program is structured in Uganda. It's located within the National Emergency Operations Center, which is a unit which is under the National Institute of Public Health, but it has very strong linkages to the regional, district, and community levels. We have several stakeholders, but one of the major stakeholders that we have in this is the communities. Because in Uganda, we recognize that all outbreaks start in the community, they affect the community, and they are actually ended by the community. Several other partners, including Africa CDC, Baylor IDI, and so. Our key objective in the unit is to make sure that we support early detection of all public health threats in and around Uganda. When I say around Uganda, Uganda is surrounded by several other public health sources of public health threats. So these are our sources of information. Apart from the health facilities, we have schools, which are a great generator of EBS information. The communities, needless to say, media, animal health, very important, and then the laboratory, which generates signals. These are triaged at the national EOC, and in the process of verification, we always reach out to the source. Now, several of these signals come from the community, but at the national level, we do as much as possible not to contact the community member directly. we would rather the region or the district does it as a way of strengthening systems. Although several of the signals that we get have phone numbers, as I will show you, of the people who have reported us these signals, we do our best to hand this over to the district because they are the custodians of all health information within their districts. So depending on the verification stage, the signal can become an event and an alert. Several of them don't make it through to alert level, but in case it's an event, we hand this over to the laboratory, depending on the pathogen or the, depending on what we are suspecting. Some of them will require a laboratory diagnosis. Some other conditions like malaria, which is endemic in the country, typhoid, will require other algorithms for us to confirm an outbreak. I'd like to give a simple historical journey of EBS in Uganda. Well, it can date back, but these are the key milestones. In 2013, we have the National EOC established. And this was a collaboration between US CDC and other partners with Ministry of Health. We find that a very big milestone because, as I mentioned, that the EBS unit up to now is anchored within the National EOC. In 2016, we have training from US CDC and Georgetown University, pardon me for that. And in this engagement, we get to develop curriculum and training of the National EOC team members in event-based surveillance. In 2018, just 1 year after the Africa CDC was born, the EBS unit is formally established in Uganda. And there was recruitment of an EBS analyst. We also had a strengthening of the community-based surveillance line. We call it the 6767 in Uganda. This is an SMS line that any community member or health worker, anybody, can use to report any signal to the national level. It's free of charge, of course, to the reporter, but somebody has to pay the bill later on. It's within the same year that Uganda got trained in the epidemic intelligence for open sources, which we find as a very great milestone. COVID-19 taught us that the national level cannot handle all, the national EOC cannot handle all signals that are coming from the communities alone. So in 2020, the Director General of Health Services moved to establish regional EOCs. So far, 6 of them have been established, and it is within them that we get to triage and also validate some of the signals. IDSR third version is a big deal to us. 2021, they are adopted, and right now we are training, we are rolling it out. I remember during our adoption meeting, somebody had to fly from African Union to come and join us in that workshop. So that will make sure that EBS is part of our IDSR guidelines, which is a very big achievement for us. And in 2022, sorry, the year disappeared there, this is where African CDC formally came and established the materials. We adapted them for Uganda using the framework that we get from Africa CDC. And those are the ones that we are using up to now. I wanted to give some of the success stories. There are so many. If I was given a chance, I would cook the whole day, but I'm standing between you and the lunch. So I will be brief on these ones also. So as I said, we have tools that have already been adopted in Uganda, and these are the ones that we are using for implementation. In Uganda, at least 55 national level trainers have available to train subnational levels. We also have finalized our M&E framework in EBS. It's the one that we are using to monitor our performance. A signal list has been approved by the topmost organ of the Ministry of Health, and it covers One Health. So we have signals for community, we have signals for animal health, we have signals for environmental health. And then job aids, there are so many of them that we're using. For example, this one, we used it during the Ebola outbreak we handled last year, showing how signals can be acquired, how they can be registered, verified, and also what happens if we have them graduate to the next level. As I said, IDSR, Integrated Disease Surveillance and Response, is a big deal to us because in it is a module for EBS. So this is a map of Uganda smashed a little bit, sorry about that. But it shows where we have already spread IDSR. The regions that are not shaded are the ones that we are yet to spread out our IDSR gospel. Hotline EBS is ongoing at the national level, actually in the Emergency Operations Center. And Africa CDC has supported us to roll it down further. So for now, we have a hotline EBS in 3 districts. EMS is a work in progress, but we are so excited about the system because so far we have been able to detect several signals and also lodge them. Before we could get hundreds, if not thousands of signals, but accountability is not there. 1 year, 2 years later on, we do not have where to say we triage so many signals. But with the emergency management system, this is a record, provides a record for us to make sure that they are archived very well. And we are also piloting a spread out of EBS in several health regions. So far, we have done this within the Kabalore region, and we are moving as One Health. I talked about the 6767 line in Uganda. This is where a community member is enabled. You don't have to be registered, not at all. A community member is enabled to send a signal about anything that they perceive to be of public health importance. And these are some of the signals that we got and verified during the year 2022. As you can see, they come in their thousands, sometimes hundreds and thousands. And the spike we are seeing around October, December speaks to the Ebola outbreak that we had within our country as we are responding, where we had heightened level of awareness within the country, and many community members and health facility practitioners could report to us. Talked about the regional EOCs and why they are a very good deal for us in the implementation of EBS in Uganda. So far we have 6 established and we have 4 in the formation. As you can see, covering 63 districts out of the 140 districts. The bias is so much on our border between Uganda and Congo for obvious reasons, which you might know. There is a very thick tropical forest over there, and in it we have both known and unknown pathogens. So that's why a priority was made for that stretch to cover the regional EOCs. And we also have another regional EOC that is covering down east or southwest towards Kenya. That region is so plagued with anthrax, and actually even now as we speak, we are responding to an anthrax outbreak. The metropolitan area around Lake Victoria there is also where the biggest population of Uganda is. That's Kampala and Wakiso. So that's why we establish a regional EOCs. So what is the contribution of these ones in EBS implementation? It is the regional EOCs that help us to triage and validate the signals. If I was given chance to elaborate so many of the examples and the success stories that we have achieved, but I will give only 2 examples. Now, in the bottom left, this is a snapshot of a signal that we get from one of the community health workers. I will read. As I said, we have the chance of getting the number who has responded to us, and that's the phone number. I am sorry for the breach of confidentiality, but this one is a fellow health worker at the community, so we can be able to show the number. But on one blue day, he goes into his phone and gives us this alert. It says, alert 5-year male suspected meningitis case with 2 days of history of high-grade fever, severe headache, altered meditation, stiff neck, in Block D, Dongo. So this comes from a refugee settlement somewhere in West Nile. And when we get it as fluid as is, in the EMS we have a way of coding it. The way you see why it's closed, because we triaged it and we validated it. So in the EMS, it graduated actually from signal to being an event and alert, and actually it's a full-blown outbreak. So because of this one, we were able to detect this outbreak, and by the March 7th of this year, this is a C-trip that we get from the regional EOC on the left, sorry, it is your right, it's my left. One of the successes showed that innocent SMS helped us to detect a meningitis, bacterial meningitis outbreak. By that time, we had 16 people involved. By yesterday, actually, the numbers had increased. We saturated the C-trip that shows more numbers. But this is one of the success stories. Also, during our Ebola outbreak, we had a heightened way of telling the community, if you see anything, please let us know. So this is one of the signals that we get from social media. The reason why you don't see a number there, it's a snapshot from our EMS, by the way. It's because it came from social media. So someone in the marketplace goes to their phone and say, a female with blood coming out of the mouth and ear collapsed and died at Nakasero Market on 11th of October 2022, 8:30 p.m. The body was taken away to police in that vehicle number. So we got interested. It came through. And actually we validated it to be very true. And we sent our emergency medical services there as part of the triaging. We picked a sample. Lucky enough, the sample tested negative for a VHF. So it graduated from being a signal to an alert. It never made it to an alert, sorry. This will be my last slide. Some of the notable challenges and workaround solutions. So as we have already seen, we are yet to spread out IDSR version 3 in the whole country. The regions that I showed in the map shows spreading up to regional level, but we still have to cascade it further to district, to community, also health facility level. So we're outsourcing partner support to help us with that one. EMS is an exciting venture in our country, very, very important, but it's work in progress. Also need to roll it out to the regional EOCs. So we are engaging formal engagements with South Africa, Uganda, to help us with this one. As you saw, we get so many signals from the community. We get so many signals also from the facility, but we are thin. In the national EOC, we are only 2 people doing the triaging. So we are managing this somehow with engagement with the regional EOCs to validate and verify some of these signals. And formally, we want to roll out EBS modules in all health regions. So far, we have done it in one health region, that's Kavalore. We would like to have all 16 regions covered. And that's why we're reaching out to partners like the people in this room to help us with this. I thank you very, very much.
You did it.
Oh, did I spoil the lunch?
No. Yeah, excellent. Thank you, Joshua. So a real experience from Uganda involving the community in signal reporting, how they have been using that one to triage and triangulate information. So that's really very fascinating experience. So I think I will not do a good service if I will not open at least for 2 questions from the audience. So let me do this. I will give you a chance for 2 burning questions, but it has to be from women. Because I think men have been really speaking too much this morning, so 2 burning questions from women. Excellent. One from there. Yeah, I'll come, yeah.
Thank you so much for the beautiful presentations across the countries. So my question is actually on the sustainability of EBS across. Yes, we've heard a lot of wonderful things being done, a lot of systems, platforms being put in place, and we all know from the presentations from yesterday till today, the cost the human resources required and also the cost. We're talking about hotline, we're talking about, EIOS and the need for internet data for all this. So how are the countries coping in this, especially with the deployment to the subnational level, such that, it's not just a, one-off thing, and then, even we know there is a lot of, partner support in this. So what's the plan for sustainability to ensure that, there is continuity and sustainability? Thank you.
Excellent. Any of the presenters can take that one. If partners want to reflect, and even they commit dollar amounts here, so I think that's fine. So the second one, yes.
Yeah.
Great.
Thanks.
Global Fund.
Dr. Yenu, is this me or?
Yeah.
Okay,
Yeah.
thanks. Thanks very much to all the presenters, as well as the question about sustainability. I had a very similar question. One thing that I noticed in all the presentations is that the overwhelming nature of event-based surveillance, where there's a number of signals and there's not enough people to triage and verify and perhaps even investigate. I think this is very important for us as an event-based surveillance community to think about how we can, as we learn from lessons learned, how can we adjust the event-based surveillance so that it's not only sustainable, but also a balance between sensitivity and specificity. I think it's a very important consideration. We've now learned for the last 4 or 5 years in different country settings how to do this. It's time now to think about how can we more sustainably do this in different settings, but also how can we rejigger event-based surveillance to be both sensitive but not very specific. Find the balance for sensitivity and specificity. Otherwise, we're going to lose our subnational levels because it's going to be too much signals that they can't handle. Thanks.
Thank you, Arun. I think that's very good comment and question. So, one last chance from men. One. No, men, okay. They are angry, okay. Okay. So the women want to take over. So, women, okay.
Merci beaucoup. Je remercie tous ceux qui ont pu présenter. Je remercie aussi l'Union africaine pour la mise en place de cet atelier. Je me présente, c'est Dr Léonie Magna de la République démocratique du Congo. J'ai remarqué dans les présentations, il y a une recommandation qui a été faite par le membre de l'Union africaine par rapport à l'appropriation de la surveillance par nous-mêmes les membres, c'est-à-dire par les pays. Et j'ai vu aussi qu'à travers les présentations, on demandait surtout que le partenaire puisse venir appuyer. J'aimerais un peu que l'Union africaine nous aide, nous, l'Afrique, à réfléchir par rapport à quel mécanisme, comment impliquer nos gouvernements pour appuyer cette surveillance, surtout la surveillance basée sur les événements. On a donné beaucoup de recommandations, mais qu'on réfléchit quel mécanisme mettre pour que le gouvernement, nos gouvernements, je me mets aussi là-dedans, c'est-à-dire nos gouvernements puissent vraiment s'approprier du système de surveillance basé sur les événements et voire même la surveillance elle-même. On ne réfléchit pas trop sur ça et nos gouvernements ne s'approprient pas. On a toujours un regard vers les partenaires. Merci.
So, thank you very much. So, who wants to respond from the presenters? The last question, Dr. Benjamin will respond to the last question. And then sustainability and sensitivity of your event-based surveillance, who wants to address? Joshua will address. Excellent. Dr. Benjamin, go ahead.
Bon, merci beaucoup à la représentante de la République démocratique du Congo. Étant étant donné que la question a été posée en français, je vais répondre en français. En ce qui concerne l'appropriation par les pays, c'est une question très cruciale. C'est de faire justement, aujourd'hui par exemple, si vous prenez sur l'ensemble des pays africains, le rang qu'occupent par exemple les ministres de la santé dans le cabinet, ils sont complètement au bas de l'échelle. Ils ne sont pas au niveau... Le ministère de la Santé, en réalité, n'est pas un ministère régalien. Et il faudrait en faire, justement, un ministère régalien, parce que les questions que nous nous posons dans le domaine de la santé, les ministres en charge, par exemple, de la défense, ne se posent pas de questions. Quand on veut acheter des armes, on ne demande pas de l'aide pour acheter des armes. Nous trouvons les moyens pour acheter les armes, par exemple. Vous voyez? Donc, comment faire en sorte que la santé soit une priorité? L'épidémie, la pandémie de Covid-19 est un bel exemple. C'est un bel exemple parce que les guerres n'ont jamais empêché aux gens de voyager, les guerres n'ont jamais empêché aux gens de commercer entre eux, les guerres n'ont jamais empêché la société, justement, de bouger. Mais les épidémies, les maladies le font. Nous avons vu cet exemple-là. Et si cet exemple-là ne nous sert pas à tirer des leçons pour le futur, ben nous n'aurons rien appris. Donc c'est justement de continuer à porter ce message, à continuer à faire le plaidoyer, de sorte que les États prennent la mesure de l'importance d'avoir la santé comme une priorité dans l'agenda de développement et dans l'agenda politique tout simplement au niveau du pays. Nous allons continuer par exemple, nous à notre niveau, de faire le plaidoyer au niveau continental, au niveau de l'Union africaine, pour que les États tirent les leçons de cette pandémie-là. Mais le reste doit se faire dans le pays et il faut maintenant, de manière concrète, qu'est-ce qu'il faudrait faire? Il faudrait avoir des alliances au niveau du pays. Par exemple, on a parlé de 15% de la part du budget national annuel qui doit aller au secteur de la santé qui ne se fait pas. Par exemple, quand nous, pendant la phase de préparation du budget national, il faudrait que les ministères de la Santé s'entourent, par exemple, de la société civile. La société civile peut servir vraiment à ce niveau-là, à faire du bruit pour qu'on puisse, par exemple, augmenter la part du budget national alloué à la santé. Que les différentes commissions au niveau de l'Assemblée nationale, par exemple, la commission santé, la commission budget et autres, tout ça, puissent avoir un dialogue. Et c'est des dialogues qu'il faut organiser au niveau du pays pour que les gens saisissent les différents enjeux. Sinon, ça va être extrêmement difficile. Voilà, par exemple, un exemple concret de ce dialogue national à organiser avec la société civile comme partenaire pour pouvoir faire avancer l'agenda de la santé au niveau des États. Je vais m'arrêter là. Il y a beaucoup d'autres pistes, mais je donne juste cet exemple-là. On pourra justement en parler en aparté autour de pause café ou déjeuner et autres, tout ça, mais je préfère m'arrêter là. Il y a d'autres pistes. Merci.
Thank you, Dr. Benjamin, for that comprehensive address to the question raised, which actually, categorize the initiative both at country level and then also as regional organization, continental organization, civil society, and also other partners. So thank you. So Joshua, you take over the other two questions.
Okay, thank you very much. The question was about sustainability. There are several other approaches that can be suggested, but I think let us get the model which African Union is using. Train, equip people, the health workers, with the knowledge. This is very important. So with the exception of staff turnover, if the local health workforce is equipped with the knowledge, other factors constant, I think that is a good way of us ensuring sustainability. Also have examples from where we recruit health workforce from within existing departments. You don't go recruit from elsewhere. I'll give an example from Uganda. Uganda, when the ABS analyst was recruited, we identified them within the existing staff. So it was like an additional role on top of your role. So that one helps us with human resources. Also, there are several implementation mechanisms that countries may adopt. The question was about internet bundles for us to access EIOS and ETC, which is a very big bother. In Uganda, what we decided is to enable somebody in the community to be able to report using a simple SMS. And it's free of cost from their side. Of course, somebody pays the bill. But we wanted to make sure that this does not hamper us to get this signal from the community. So we're thinking such mechanisms can be a wonderful way of us ensuring sustainability of our ABS units. And also lastly, we have learned that certain programs pick momentum as they go on. So the key here is persistence. We will not have a wonderful, a fully blown EBS program. The first year, the second year, the third year, we have established it. So let us give it time. With persistence, we'll get there. I submit.
Excellent. Yeah. Thank you, Joshua. So I think that concludes this morning session. I think this has been a very helpful session. So we launched the documents officially, and we listened from Africa CDC in terms of our mandate, and we also listened into real country experiences from Kenya, Zambia, Tunisia, Uganda. So I think those are really encouraging developments. And in terms of sustainability, and I think let's demonstrate that it can be doable. We can do it. Let's show the impact at a small scale, and then success will bring success. So we demonstrate that one to international community, to the funding agencies, to our governments, and also remember that we said during the first day that this is a time to call upon all partners and government agencies to fund on early warning system, because we know how we went through on COVID-19, how many trillions of dollars we spent on a single agent. If we have spent that one, a fraction of that one on our early warning system, so that could have been a different story. So I think that's also important to keep in mind. So I'm really honored to have been your moderator this morning. So now you are free to go to lunch, and I think you deserve to eat lunch. Thank you.
Good afternoon. Welcome back. I appear to have a bit of an echo. Hope you can fix that. I hope lunch was good. Apologies, we are starting slightly late, but we'll make up time as we go along. We're just about to get into the panel discussion on the role of the National Public Health Institutes in the establishment of resilient early warning systems. And this will be basically a look into the Africa CDC story, and each of the panelists will speak to that. Our moderator for this particular session is Dr. Merawi, who I'd like to call up on stage. A round of applause for him. And we actually have designated seating, so you will be right over here. Thank you. Joining him is Dr. Oyeladun, who is the acting director of the Head of Surveillance and Epidemiology Department in Nigeria, CDC. Can we give her a round of applause? Fantastic. If you can sit right next to the doctor. Thank you. And Dr. George Alain, who is currently serving as the Director for the Control of Disease, Epidemics, and Pandemics in the Ministry of Public Health in Cameroon. Round of applause for him. And you will be seated here, Monsieur. Thank you very much. And our last panelist is Mesfin Wasson, who is the Director of the Disease Surveillance and Health Emergency Response Directorate, working as an incident manager for COVID-19 pandemic drought health response under the National Emergency Operation in Ethiopia. Round of applause for all of our panelists. And Dr. Merawi, the floor is yours.
Thank you very much, Madam Moderator. Good afternoon. I think it has been really a very great day, colorful day today to launch this EBS resources, and congratulations for the EI team in Africa CDC. Our panel here is today we are going to discuss about the role of National Public Health Institutes in establishment of early warning systems. And with the main thing here is to really discuss and learn from their experiences and their challenges and successes from our member states, then advocate for establishment of such a system and prepare what, or get some recommendation what needs to be done next. I think we will learn from their experience moving forward. I have like two questions for each of you. I hope in very limited time, as you can see it, and I will give you the chance to reflect on that. And later on, I will also open the floor for 3 minutes for the audience to reflect on. Then we will conclude finally I will give you 1 more minute to wrap up and conclude. And that is how we are going to really handle this session. And thank you really very much, panelists, for joining us in here. And it's wonderful. Let me begin with the first question. Dr. Oyeladun, here with us from Nigerian Center for Disease Control and Prevention. My first question is to you. Thank you very much, madam, for joining us here. Early warning systems are part of the essential functions of an NPHI. In your role as the head of surveillance and epidemiology department at Nigeria's Centers for Disease Control and Prevention, how do you think NPHIs can advocate for and champion the establishment of early warning system?
Okay, thank you. For NPHI, as part of the mandate for most of the National Public Health Institutes, we actually, one of the mandates is to strengthen early detection, early verification, and also to be able to mount appropriate response to public health events, which is the core functions of the early warning system. And the best approach to this is to ensure that the National Public Health Institutes provide evidence, which is one of their core mandates, in the process of gathering data, analyze data of public health events to provide the adequate information that is required to provide an evidence to the policymakers, to the public, to the general public, that the early warning system is crucial and important aspect of the early detection, prevention, and control of any public health event, and also saves life. Also, the National Public Health Institute are also involved in generating data via researches, and they can research into an early warning effectiveness, further providing information to the public as well as to the policymakers. And also, if we look at another angle, National Public Health Institute majorly coordinates a multi-sectoral approach, which is a One Health approach via stakeholders engagement, bringing together different government sectors, different public health workforce, different partners within the country and international partners as well. We can use that medium to create awareness around early warning system. And doing so, we can as well use this medium to also drive policies for inclusion, development of early warning system within the country, as well as for inclusion of this strategy into the country public health surveillance system, so that at the end of the day, we'll have a policy to advocate to policymakers for increased investment in health, to be able to provide enough technology that is needed, as well as the tools available. And one advantage of having policies in place is also to be able to leverage on national social medias, as well as the different data tools available in the country, to provide the real information, data to the public, as well as engage the public on what is going on around the public health space. And most importantly, MPHIs also are involved in monitoring and evaluation process, which we can also use to monitor the trend as well as the effectiveness of the early warning system in country, for countries that have been able to establish this system. And looking at the reports that would emanate from the evaluation, we can use it to further buttress and further strengthen and improve on the early warning systems around the country. So in conclusion, I would say that advocacy and it's a major tool that can be used, leveraging on the National Public Health Institute across Africa for the establishment of the early warning system. And by so doing, at the end of the day, we're saving lives, reducing the impact of the outbreaks in terms of reducing the mortality, as well as reducing the economic burden and the impact of public health events across countries. Thank you.
Thank you so much, Dr. Oyeladun. Thank you very much. I think, and it was very well said. Generate data, information, and drive policy, advocate and engage at all levels, in all opportunities, in multi-sectoral engagement, and move on to have, I think, streamlined in all other sectors as well. That is how I captured it. It's a really very, very important piece. Thank you really very much, Doctor. I will move on to my second panelist from Ethiopian Public Health Institute. Mr. Mesfen, what are some of the challenges of NPHIs to fully establish a functional early warning system? Could you share some of your experiences? Thank you.
Okay, thank you, Dr. Marawi. As you know, Ethiopian Public Health Institute, which is a technical arm for the ministry, are working on the strengthening the public health emergency management of the peoples, and we are also trying to establish robust surveillance to ensure early warning systems are in place across all corners of the country. As you know, under the umbrella of surveillance, we are trying to establish indicator-based and event-based surveillance system in all parts of the country. However, there are some challenges in the coverage of the surveillance system to ensure the early warning. The first one is infrastructure. As it is well known, there is no full-blown connectivity and infrastructure at all part of the country, particularly the rural part of the country, which are unable to capture real-time information, and so that prompt response will be ensured. And we are also trying to establish a mobile health team to make sure that indicator and event-based surveillance are in place. And there was also some man-made and natural disaster in northern part of the country, including drought-induced health-related issues in the eastern part of the country, which are unable to capture real-time information. We are trying to deploy a mobile health team to make sure that real-time informations are in place. As it is well known, even though we have full-blown indicator-based surveillance, our event-based surveillance is not optimal, particularly at lower level. It's well known that we have prepared a very comprehensive event-based surveillance, including the training guideline, and we have also established a national hotline, which is informative and interactive-based hotline system, in which all alerts or signals are captured in web-based manner, and information is also provided to the community on the current health threat. However, in the lower level, even though we have regional and sub-regional hotlines, it were not tailored with a national hotline, so that real-time informations are not available. As a quick wins and as a solutions, we are trying to empower and strengthening human resource by providing frontline field epidemiology training across all districts and at a zonal level, and also trying to integrate the indicator-based and event-based surveillance system in our frontline field epidemiology training program, so that people at the ground level will be aware on how to early detect and provide prompt response and report the real-time information of surveillance data to the national level. The other one is the one, as you know, most of the public health risks are coming from zoonotic, and we are also trying to establish a very well comprehensive One Health Steering Committee at national level, but it's not optimal at lower level, and this will compromise our multi-sectoral collaboration and coordination toward this responding to the zoonotic disease. And this is also compromise our real-time information from different sectors. So we are trying to ensure interoperable systems of capturing events at lower level, and also reviewing with the National Health Steering Committee. The other one is the DHIS2. We have utilizing DHIS2 for the indicator-based surveillance, which is implemented across all governments, private health sector. However, our event-based surveillance capturing system or event data management system is not triangulated or well organized at regional level, and we are also trying to ensure and incorporate our event-based surveillance system to the indicator-based, which is a DHIS2 system. So we are witness that event-based surveillance is very short time and resource effective, unlike the indicator-based surveillance, but integrating the system with a routine digitalized health system and providing capacity building across all sectors, including the human health parts, is very crucial, and we are working together on that, and we are now progressing very well toward this, ensuring the early warning system. Thank you, Dr. Marawi.
Thank you, Mr. Masfen, for sharing us your challenges. I think what I captured is challenges in infrastructure and connectivity across all levels, including at lower level, and inaccessibility in some situations. Some districts are not accessible for man-made or human-made or whatever reasons, including security. And I think hotline penetration is not or decentralized well, and maybe also this One Health and is not at optimal level, especially at lower level, and interoperability are some of other challenges. And I think the way they try to handle is integrating with the existing system and having more workforce development in that space. Thank you really very much for sharing those challenges and experiences and the way you handle the matter. All right, good. Thank you very much, Masfen, for sharing that. My next panelist is Dr. Tonde from Cameroon. Thank you for joining us here, Director. My question to you is, Africa played a pivotal role in the response to COVID-19 and Ebola. How can we scale up early warning system to ensure a timely response to future outbreaks or pandemics from your experience in MOH Cameroon? Thank you.
Merci beaucoup, mon cher ami, de m'avoir invité. Comme j'ai dit, je vous ai vu arriver à Africa CDC. Je vois que vous avez pris du galon. Vraiment, j'en suis ravi. Peut-être que mon propos va être un peu différent. Peut-être que je vais choquer certaines personnes. Peut-être qu'on estimera que je suis hors sujet. Mais je vais me permettre, je ne sais pas si ça arrive souvent, d'être dans un tel panel et de vous parler avec le cœur. Pour vous dire que vous avez eu raison d'aller évoquer Ebola et d'évoquer Covid. Il y a une première chose, c'est que aujourd'hui, plus que jamais, les enjeux pour les États de sécurité militaire, c'est-à-dire la menace avec les armes, sécurité militaire, de sécurité, de sûreté, on se rend compte que ces enjeux et les défis qu'ils nous imposent sont exactement les mêmes que les enjeux de sécurité sanitaire. Nous le disons, mais nous n'en sommes pas convaincus. Je vais souvent revenir sur cette affaire de convaincu, parce que si vous n'êtes pas convaincu, vous ne serez pas convaincant. Moi, j'en suis convaincu. Je vais vous démontrer pourquoi j'ai été convaincant. Vous devez d'abord être convaincu que c'est les mêmes enjeux, c'est les mêmes défis, c'est les mêmes stratégies, donc forcément c'est la même logistique, c'est les mêmes finances. Vous n'en êtes pas convaincu. Et je comprends parce qu'au moment où il faut donc décider de ça auprès du président de la République, il y a de l'autre côté les gens qui sont détenteurs des enjeux sécuritaires. Et Benjamin les a appelés les ministères régaliens. Il y a les ministères régaliens, il y a le ministre de la Défense, celui de la gendarmerie, celui de la police, celui de ceci. Ils sont au moins 4 ou 5 ministres régaliens puissants face au petit ministre de la Santé. Ils ne peuvent pas se faire entendre. Voilà d'abord le problème. C'est ça. Maintenant, pour qu'il se fasse entendre, j'ai compris que son arme, c'est les instituts de santé publique ou ce qui en tient lieu. C'est pour cela que vous, les responsables des instituts de santé publique, il faut bien m'écouter. C'est vous, c'est entre vos mains. Alors quand nous nous réunissons, vous vous réunissez et que nous parlons comme vous parlez là, vous voulez vous convaincre vous-même, vous parlez des réseaux, vous parlez des infrastructures, vous connaissez tout ça. vous avez les solutions. Ce n'est pas ça le problème. Le problème, c'est que chez le président, il y a une table, il y a un gâteau, il doit le partager entre les gens qui ont les armes et vous. Il vous donnera toujours la plus petite partie ou alors il ne vous donnera rien. Alors comment faire pour y arriver? Voilà. Avec Ebola, avec Covid, j'ai compris que chaque matin, quand le président de la République se lève, il demande des nouvelles de ce qui se passe chez les militaires et il demande des nouvelles de ce qui se passe chez Covid. Il le faisait chaque matin. Donc, j'ai dit au ministre que, mais, monsieur le ministre, nous tenons, enfin nous les tenons. Donc, nous nous sommes débrouillés pour que chaque matin, le président soit renseigné, comme il faut. Et après, quand Covid a baissé, nous avons maintenu la pression pour qu'il soit renseigné pour toutes les autres choses. Alors, les autres choses, là, c'est quoi? C'est donc là où la surveillance basée sur les événements intervient. Parce que quand il s'endort le soir, il est tranquille. Quand il se réveille le matin, il a déjà un renseignement qui parfois est donc une fausse alerte. On a dit, monsieur le président, il y a des dizaines de Camerounais qui sont en train de mourir là-bas. Le ministre de la Santé ne fait rien. Il se met à nous taper dessus. Or, désormais, ce genre de choses-là qui constituent donc des alertes, des signaux chez vous, nous est transmis par notre système basé sur les événements. Et c'est pour ça que chaque matin, chaque jour, nous pouvons donc renseigner avec justesse le président sur ce qui s'est passé. Donc, la surveillance fondée sur les événements, pour nous, dans les instituts, est notre arme fatale pour être en avance en termes de renseignement, d'espionnage auprès du président, de gagner sa confiance, de gagner d'être crédible et peut-être de nous donner les choses. On dit ça au Cameroun pour dire de nous donner les moyens. Et je peux vous dire que moi, au ministère, il nous a donné. Il nous a donné pourquoi? D'abord, si quand vous allez venir au Cameroun, vous allez voir que le centre des opérations des urgences est protégé. J'ai des policiers qui gardent le centre parce qu'on a compris que c'est un endroit important. Quand j'ai eu besoin parfois d'un certain argent après le Covid, on nous a alloué le genre de financement qu'on nous donne qu'aux forces de défense. On nous a déjà alloué. Je ne vous dirai pas le montant parce que vous allez commencer à... Et plus loin encore, nous avons organisé un forum des urgences de santé publique en décembre pour faire un peu le point de tout ça. Et vous savez quoi? Le président et le Premier ministre nous ont demandé, ils nous ont dit, parce que nous plaignons tous les pays là que nous avons besoin dans les institutions de santé publique d'avoir des fonds d'urgence en permanence qu'on peut sortir pour déployer les équipes. Nous demandons ça depuis. Moi, j'ai obtenu ça au Cameroun, où le Premier ministre et le président m'ont dit, bon, comme tu te plains que tu n'as pas souvent les fonds capables de déployer, vas-y, rédige-nous le texte qui organise la mise en place des fonds d'urgence au Cameroun. Et nous sommes en train de le faire. Et les prochains directeurs, j'espère, le prochain ministre de la Santé publique, ceux qui vont venir après nous, auront ce fonds que j'estime comme ça, sans avoir travaillé, qui sera au minimum de 2 milliards et demi au minimum. Donc, c'est pour vous dire que la surveillance fondée sur les événements, la mise en place des instituts de santé publique, c'est vrai, ça repose sur tous les aspects technico-infrastructurels dont nous parlons là, mais ça repose d'abord sur le fait que nous devons être convaincus de notre utilité, nous devons savoir faire le plaidoyer, nous devons réclamer notre place, et que cette place, nous allons la réclamer bien sûr en fournissant les résultats, en continuant à être crédibles, en construisant ce qu'on construit. Voilà ce que je voulais échanger avec vous pour l'expérience du Cameroun. Merci.
Thank you, Dr. Itonde, for that reflection. I think the first thing is we need to be convinced with our mandate ourselves, then we convince others. That is the main thing that I captured. And to get engaged with the political leadership, we need to continue to have this momentum, the current momentum with COVID-19 and other disease outbreaks, and regular briefing shall continue. I think that will give us a leverage to scale up our early warning system. And we need really to give them a very good briefing and convince them so that we have a trusted and credible system to be established and resources allocated with all other competitive ministries and competing priorities. Thank you very much, Dr. Itonde, for that wonderful reflection. I hope we are all getting some insights on this. Let me move on to my next question. I am coming back to NCDC. My question is, understanding the need for capacity building and strengthening for early warning system, how can Africa position itself to address these gaps through national public health institutes? Thank you.
Thank you for the MPHI, especially in terms of the capacity for early warning system. Across Africa, you agree with me that when it comes to especially some IT experts, we're low in capacity in Africa. We're low in even funding in terms of resources, as well as the technical know-how. And the past or the current pandemic has shown that when it comes to public health, no single sector, be it health, or be it agric, or be it the MPHI, has all the capacity it takes to effectively respond to the outbreaks of such magnitude. So it takes a village, actually. Vulnerability to one is vulnerability to all. So for the capacity challenge, the gap, I would say, is a multifaceted approach. It involves collaboration across all sectors. It involves partnership, and also involves policies, as well as the government ownership in terms of ensuring there is adequate funding for investment for health. In terms of this capacity challenge, we can leverage on the strong partnership and collaboration with partners, be it regional partners, international partners, to ensure that we leverage on their knowledge as well as capacity, and also ensure they build country capacity, while also supporting us in establishing this early warning system in country. Would also leverage on this process to ensure there are policies in place for government ownership, so that government would ensure that they vote enough resources, allocate funding for early warning system within country. This is to ensure sustainability and also to ensure ownership and continuity. We all know that we can't be over-dependent or over-reliant on partners' fund at a particular point. Resource allocation. Apologies for that. Another recommendation also, it's partners like African CDC. They can also engage and work with National Public Health Institute, like NCDC, to ensure that we have programs or priority program that will drive institutional capacity and ensure that we have technical expertise that will work with the workforce within the MPHIs to build their capacity in terms of this process. And by so doing, over time, we'll be able to bridge the gap in terms of capacity for the early warning system. Thank you.
Thank you very much, and CDC, for highlighting how we can address the capacity gap. I will not summarize for the interest of time. I will move on to my next speaker, Mr. Masfen, Ethiopian Public Health Institute. How can NPHIs adopt a whole of society approach in building and utilizing early warning systems in member states? What has worked for you? If you share your experience, thank you very much. Yeah.
Thank you so much. Currently, we are trying to customize the third edition of integrated disease surveillance and response with the umbrella of public health emergency management. We have using the approach of multi-hazard approach, which is a public health emergency management, and we are also trying to customize the event-based surveillance system, which is currently launched, and we have already prepared our guideline for the latest edition of public health emergency management. Also, we are preparing the national event-based surveillance guideline, including the training manual, which is previously accredited by university. So by using these resources, we are also trying to cascade to regional level so that regions will be aware on the current protocols to implement the early warning system as well as the emergency response with uniform manner. As you know, real-time information should be captured in digitalized manner. So we have used currently the DHIS2 platform for the indicator-based and trying to also integrate the event-based surveillance. And we have established the latest technology of hotline in collaboration with Ministry of Science and Technology, which is voice interactive. Current messages and informations will be delivered to the community with this technology, and alerts and signals are also captured by this voice interactive management. So we have dedicated hotline experts working 24/7 so that every alerts are being verified for prompt response. The other one is, in order to ensure this early warning system, we need to also establish well-organized emergency operation centers at national and regional levels to facilitate real-time information's availability as well as provision of responses, public health emergency responses. So we are addressing the regional needs to establish this emergency operation center, and we have already established the National Emergency Operation Center. And currently, we are also trying to cascade these emergency operation centers at ground level so that emergency will be handled by the ground experts. The other one is, in order to facilitate and fast track all endeavors, trained workforce is very crucial. In this regard, we are also trying to integrate all early warning, preparedness, response and recovery activity with the umbrella of this field epidemiology training program. And we have already accessed 75% of district level surveillance officer. And also we have also trying to reach the health facility surveillance officer, since health facility is critical and epicenter for surveillance data. So these are major milestones that we are trying to recover as a challenge, as we have told you previously. Provision of well-organized training in full-blown and integrations with multi-sectoral issue is very crucial. Back to you. Thank you.
Thank you. Ethiopia. So I will not summarize again here for the interest of time. I will move on, Dr. Ritonde. My last question, then I will open the floor to the audience. The African Union Agenda 2063 and the new public health order are blueprint frameworks that guide Africa towards achieving its health security. Building an early warning system is situated in the core of these frameworks. How can NPHIs or member states be held accountable to these commitments made? if you share your experience or give us some insight about. Thank you.
Merci beaucoup. Non, je crois que j'ai dit ce que je pensais. Je pense que je le redis là. Je crois que les instituts de santé publique et ce qui en tient lieu sont vraiment, comment dirais-je, notre arme fatale pour que la notion de sécurité sanitaire soit ancrée dans la préoccupation première des chefs d'État. Dès que vous avez obtenu ça, tout le reste va suivre. Et forcément, si les États sont forts, l'Union africaine en ressort aussi plus forte. Vraiment, nous devons tout faire pour obtenir ça. Et tout faire pour obtenir ça, c'est dans notre façon d'agir, de nous organiser, c'est sûr, mais aussi c'est dans notre façon de savoir mener le plaidoyer. Et je le redis ici, la surveillance fondée sur les événements, qui est l'équivalent de l'espionnage et du renseignement chez les militaires, c'est encore ce qu'il nous faut vraiment. Parce que s'agissant du niveau communautaire, là aussi, nous devons vraiment lâcher. Nous ne devons pas aller à former à la communauté en gardant les vrais pouvoirs. Laissons la communauté s'approprier de cette notion de surveillance fondée sur des événements. Laissons l'organisation administrative et politique du pays s'impliquer et s'approprier. Dans un département, dans un district de santé, si le préfet, si le gouverneur sont conscients du fait que s'il y a un problème de sécurité sanitaire, le président ou le premier ministre vont lui taper dessus, il réagit. C'est ce que nous avons fait au Cameroun. Aujourd'hui, quand on a eu la menace à la frontière avec la Guinée équatoriale, quand nous avons envoyé nos équipes d'investigation rapides sur le terrain, c'est le préfet du département qui a conduit les équipes parce qu'il savait que la présidence, que nous avions déjà informé la présidence de l'imminence du danger. Donc vraiment, je ne vais pas dire beaucoup de choses, je l'aurais dit. Soyons convaincus que nous sommes importants pour aller discuter le gâteau avec les ministères, comme Benjamin est déjà là, c'est pour ça que je reviens dessus. Si nous voulons aller discuter le gâteau avec les ministères dits régaliens et devenir nous aussi régaliens, nos instituts de santé publique doivent nous donner la force d'aller réclamer ce gâteau-là. Vraiment, c'est ça que je vous dis. Moi, ça va. Merci.
All right. Thank you very much, Cameron, for sharing some insight regarding accountability, how we better make accountability in setting up or building early warning system. With that, I will open the floor to get some insight from the audience as well. So please feel free to raise your hand. I have almost 3 minutes for this. Yes, share us some insight. It's not like a kind of question and answer, but to get some insight so that we can, when we go back, we implement it and we learn from the experience of our other member states who are not in the podium. Yes, thank you.
Victor Tepe is my name. I just want to follow up on what Dr. Itundi has said, which may not, which is a very great idea for the state of Cameroon and other states that are organized, you know, have that same administrative structure, and that it is great. So if your government, your governance is structured in a way that the head of state, the president or the prime minister is the one who calls the shots, then you have to make sure that your agenda somehow gets to that table. If you don't strategize in a way that your agenda gets to that table, then any issue regarding public health will always be pushed to the back. But again, as I said, different governments run differently. So as a whole, what has to happen is make sure as leaders of public health, as leaders of various structures that have to implement EBS and other tools, make sure that you are able to target the source of power the person who distributes the bread, the person who has the knife and the yam. If it's parliament, then that's where it should go. So that's just what I wanted to add.
Thank you, Victor, for sharing the wisdom. Let's know who to target to. In short, I think that's very wonderful. Any other insight regarding the role of NPHI in establishment or strengthening of early warning systems? Give us some more insight from your experience. All right, if there is no hand, so let me get back to the podium. I will give you one minute if you have anything to add or recommend. Let me start with Nigeria.
Thank you very much. Okay, so from Nigeria, the parting word, I'll say the public health event happening at any part of Africa or from any local part can go globally in a matter of minutes. And to attain global health security, we need a resilient early warning system, alerts which should be able to detect locally what is happening in our own communities. And this starts with a resilient early warning system managed by a well-skilled public health workforce with adequate coordination. And this is what we do at the National Public Health Institute, which Nigeria Center for Disease Control is an example of that. And we use the NPHI to coordinate, and partnership matters a lot to us. Collaboration would collaborate with our partners in country, at the regional level, and the international partners. So I'd like to use this opportunity to say thank you to all our collaborators, those that have been working tirelessly to ensure that we build a resilient health system in Nigeria as well as across Africa. And we'll keep advocating for more. We'll keep leveraging more on your support to ensure that we achieve health security. Thank you.
Thank you, Dr. Oyeladun. I will call in here Ethiopia Public Health Institute if you have anything to recommend or give us final remarks.
Okay, thank you, Dr. Marawi. I think I would like to recommend to have a very well organized cross-border collaboration with our neighboring countries and other member states to have a clear integrated way of information communication. As you know, something that happens in some area will have the probability to be to move in other area within a short period of time. So this cross-border collaborations and information exchange is very crucial towards detecting as early as possible and also to provide prompt response. That's one of my recommendations, and sharing of experience and other resources in which some area have some center of excellence in different subject matter. So utilizing that experiences in other area where something happen will have benefited in terms of resource as well as effectiveness. So that will be my recommendation. And as you know, we have fortunately we have one framework, which is event-based surveillance, which is an opportunity to us to have a uniform way of implementing the event-based surveillance system. But as you know, once we get clear update from other country, is very crucial for us, and also provide information for other country with this platform is very crucial. So I would like to recommend to have a uniform platform of implementing surveillance system, particularly the event-based surveillance system is very crucial toward this detections of public health threats across the continent. Thank you.
Thank you very much, Masfin. Dr. Ritonde, if you have anything to give us. Thank you so much.
Vraiment, la seule chose à ajouter, c'est que personne ne m'a invité au restaurant Le Cannibal. Vraiment, c'est la dernière. Merci. J'attends l'invitation. Merci. C'est pour le Kenya, hein, le responsable du Kenya, là. J'attends l'invitation pour le restaurant Le Cannibal. Merci beaucoup. Merci d'avoir été là. Merci. Carnivore. C'est pas le cannibale? Ah, vous voyez, j'ai oublié le nom. Raison de plus pour qu'il m'invite. Merci beaucoup.
All right. Okay. Thank you. Thank you very much. Really appreciate all your contributions, recommendations, and insights. I hope all other member states here with us today learn from your experiences, your challenges, and successes. And just to take advantage, I will not summarize, and I hope the minutes of this session will be circulated from the Secretariat. But let me just say one thing. Africa CDC has committed this morning from the Africa CDC Acting Director General. We are here to support member states, and we want to really graduate and retire from any engagement, and we empower member states. Our mandate, as presented this morning by Dr. Benjamin, is to empower the African institutions, national public health institutions, public health emergency operations centers, and you name it, all others. That is our crucial mandate. There is no country called Africa CDC, or there is no country called WHO. There is country called Cameroon, there is country called Kenya, Uganda, you name it. That is what we are really working on. We are not to take the driver's seat. We are encouraging member states to take the driver's seat, and we are committed to support that. And your priorities are our priorities. You don't have other priorities. And we advocate EI because it is very crucial and at the core of all other public health emergency activities. And we encourage EBS to be part of your processes so that you can capture health events as early as possible and you manage it. So we support those processes. I think that is a commitment we get from the Africa CDC Acting Director General this morning. With that, I will I wish to thank all my panelists here from Nigeria, Dr. Oyeladun, from Cameroon, Dr. Ritonde, and from Ethiopia, Mr. Mesfin. With that, I finish my session. Thank you really very much for your attention. Thank you.
Can we get one more round of applause for a fascinating panel there, moderated fantastically by Dr. Merawi, and the insights coming from Cameroon, Nigeria, and Ethiopia. Moving on swiftly, I'd like to introduce our next presenter, Anthony Mounts, who is a Task Force for Global Health Advisor to a Global Fund project that provides technical support to countries on the continent in developing EBS systems. And he'll be taking us through EBS maturity models and what that looks like. Can we give him a hearty round of applause here?
Thanks very much. I realize that the Task Force for Global Health is probably an organization that most of you have not heard of. We're a little nonprofit technical agency located in Atlanta, Georgia. The part of the task force you probably have heard of is TEPINET. TEPINET is one of the programs at the Task Force for Global Health, along with a number of others, which I won't go into today, but just by way of background. So the task force was recruited recently by the Global Fund to provide technical assistance to countries on the continent of Africa primarily, but also in Asia, to support the implementation of event-based surveillance. And this is a result of some of the discussions going on at Global Fund around pandemic support that was given early on in the course of the COVID pandemic, but also thinking about now how to use some of these resources for the future, for pandemic preparedness. And so we were recruited to provide some technical assistance in that regard. And one of the projects that we were given was to develop this maturity model. And the maturity model is essentially what the name suggests. It's a way to look at countries' capacities and kind of rate them in terms of their level of maturity or capacity to help identify gaps where Global Fund and other support agencies might come in and add support. And it's really also to help Global Fund to prioritize or tier countries to think about how to approach them more in the future. One important thing about this maturity model is it's not a performance measure. It's not intended to measure performance, and it's intended to measure capacity. And what I mean by that is it looks at things like funding and human resources. How well is the program staffed? How well is it funded? How much of the funding comes from government sources versus external sources? It looks at laboratory. How much capacity does the laboratory have? It doesn't look at performance of those things. That's a separate issue. It doesn't look at things like how timely is reporting, how complete is reporting, how quickly does the lab turn around results and report them back to the person submitting samples, and those kinds of things. Those are contained in the event-based surveillance framework that's now been rolled out this morning. If you look at one of the annexes there actually are performance indicators, and I think that this will help to complement some of those, although primarily the tool is intended at this point for Global Fund use. We based it on a lot of existing tools, so where something existed already, we didn't make it up. And so in places, when you read the document, you'll find language that looks very familiar because it's taken directly from the JEE or from the ESPAR or from the WHO benchmarks on IHR capacities. Other places where we couldn't find a relevant capacity or benchmark, we used something that's contained, the concept is contained in some of these other documents, but then we created a range of capacities related to that. The focus of this document is on early warning surveillance specifically, but it does contain all of the different components that might go into an early warning system. So for example, even though the focus of it is on event-based surveillance, it also has a section of questions about informatics, data transmission, data hubs, laboratory capacity, and those kinds of things. And the last point is, this is intended to be a living document. So as standards change, as our thinking about what goes into making an event-based surveillance system work, the intention is to modify this. So the organization of the document, it's very similar to another Global Fund document, which is the Global Digital Health Index indicators. Some of you may have seen this, and if you look at it, you'll recognize the similarity. Even the number of domains is the same. So it contains domains like policy and guidelines, surveillance infrastructure, workforce, laboratory systems, data systems, response capacity, and monitoring and evaluation. It's a very simple scoring system, scored on a scale of 1 to 5. 1 is nascent or essentially no capacity, with 5 being a sustainable system that functions, it has all the necessary parts to function. You can score it for each domain. So within policy and guidelines, there's several different capacities that are outlined, and you could combine those into a score for policy and guidelines, but then it's also intended to be summarized into a summary score for all domains. And the other thing about the document, the assessment, is it's largely qualitative. There are not a lot of numbers. We don't put numbers like 50% of districts will have this, or there will be a ratio of this to this, number of epidemiologists per population, for example. We're thinking about adding some of those in, but right now it's strictly qualitative, and that's in part because we wanted to make it accessible and usable, and many countries we know would not have the data that they would need to inform a more quantitative assessment. This is just one example of one line from one domain. The domain is surveillance infrastructure. And this one looks specifically at event-based surveillance. And you can see it goes from that far left second column in, nascent level, up to sustainable level. This particular domain is not about, again, it's not about function or performance. What this focuses on is structure. So one of the key components that we feel like is important for a good performing event-based surveillance system that has the capacity to perform well is that it actually has structure to it. There are signals that have been identified and defined. There are procedures that are laid out and that everybody is aware of. There are guidelines, there are policies that are developed around each of the necessary components of event-based surveillance or early warning surveillance. So this capacity is all about structure. Is there structure, or is it just an ad hoc system that relies on people to think that they should report without any system in place? And you can see that there are also a number of footnotes that will explain some of these key terms that may not be completely clear at first glance. So the next steps, right now this document's only seen very limited circulation. We've shared it with a few partners, Global Fund partners. We've gotten some input and we're going to revise the document. We would like to share it more broadly, and most importantly, we would like for some countries to look at this in your own context. We need to make sure that it actually makes sense and that we need that reality check. You might call it the laugh test. We just need a few countries to look at it, and so we're looking for volunteers. This is the first announcement of that. So if you'd like to use this and try it out in your country, please come see me afterwards. We plan to work with other partners to see if this might be useful beyond the Global Fund. As I say, it was created as a Global Fund tool, but we think that it might complement some of the things that Africa's CDC has developed for the performance indicators, for example. It would need a little bit of adaptation because there are elements of it that are specific for the Global Fund. For example, it has one capacity in there that asks about whether or not HIV, TB, and malaria infrastructure is properly leveraged to support event-based surveillance. The reason that's in there is because if you know anything about Global Fund, you'll know that historically that's what they support, procurement for HIV, TB, and malaria. And so it's part of their own internal check to understand if that's being done. But were we to adapt this for broader use, we would change those kind of elements. We think that it might be useful to not incorporate performance indicators like I've said here, but maybe to combine it with performance indicators to create a more comprehensive tool to look at surveillance systems. And in fact, I've been working closely with a group at WHO headquarters who have recently published this mosaic model for surveillance that describes the whole spectrum of kinds of surveillance systems that a country might want to institute. And we're thinking that to do a more comprehensive evaluation, we might need some combination of capacity indicators and performance indicators. And so we might look at building it into something like that. We'd like to finalize this version within the next month or two. But as I say, the intention is that this will change over time. And so finally, if you would like more information or if you would like to try this out, it's actually a very simple document, a very simple tool, wouldn't take you a whole lot of time. Please contact me at this email address. I'd be happy to share it with you and to get your input. So thank you very much.
Thank you so much. One more round of applause for Anthony Mount's extremely practical presentation there on the EBS model maturity. Our next presenter is Dr. Binyam Chakilu. is an associate professor of health information systems and implementation sciences, as well as the founding director of eHealth Lab in Ethiopia, and the vice president for research and technology transfer at the University of Gondar. Let's give him a round of applause as he makes his way up. Presenting on the African Union HIE guidelines and standards. Floor is yours.
Thank you so much. Down here. Okay. Good afternoon, everyone. So it's always difficult to present on the last day and also the afternoon of a workshop, but I will try my best to be very brief. So just to give you a context, this is the African Union Health Information Exchange Standards and Policy was a document which was done for the last 3 years during COVID. So it was like a massive work of different members. My name is Biniam. I was a technical lead for the work, representing University of Gondar. And also, he's South Africa. I think I can see Xuan, the CEO, is also here. They are also our collaborators. And also, the task force was really leaders of digital health in Africa. I think like more than 29 members were having like weekly calls to develop this during COVID time. So I think that was a massive work. Who is in the task force here in the room? How many? I think we have Dr. Ahmed, I can see that. And then we had also a validation workshop, like in the 5 regions of Africa, like more than 100 participants during this work. How many of you were on the validation workshop? 1, 2, 3, 6, 7 hands. Great, so I think like this morning, Mercy was telling you about this work, what is meant by, what's the purpose. So I will not go in detail. I will briefly tell you what are the purpose, and also I will tell you about the background, the approach, and also the highlight of what are the main results. And then finally, I will put on the next steps. I will start by saying this morning, I think Dr. Ahmed, as well as Dr. Benjamin, they were highlighting the importance of data sharing for Africa CDC, as well as how that can be achieved, and also that is like a primary one of the missions of Africa CDC, like to have different data sharing platforms. So, saying that, like when we say of this work, the end vision is how we can get data from different countries so that we can have continental level insight, as well as real-time decision making for the continent. Especially like for the last 2 days, we have been discussing about emergency and then how rapid response is needed. And then we have to do that. We have different digital health systems across the continent, but those digital health systems need to talk to each other, and also the data which is coming from different countries need to be in alignment so that we can have that aggregated view of the continent level data. So the major purpose is how we can have this interactive data analytics platform at the continent level. And then when we think of this, though we have challenges, always there are challenges if you do something. So I would say there are challenges, and then how we are going to challenge them is very important. The first challenge is we have different digital health systems. That's not only across Africa, but also if you see within countries, we have different systems. And also we are developing them using different standards. That is a major challenge. And also we have sensitivity with data. Like always, whenever we are thinking of we are going to share data, there is a sensitivity of sharing data. Like it can be across member states, even within countries. Like there is a sensitivity whenever we think of, oh, the data is going to be analyzed at the continent level. And then when the data is going to be shared. So always there are questions, which data is going to be shared, how it's going to be used. So that's another challenge. And also there is no approved standard within the continent. That's also another challenge. And the other one is, as highlighted by this morning, human capacity is the other aspect. But like moving forward, how we can challenge those challenges is that how we can develop a policy and standards that can be applicable across the 55 member states of the continent. That was the major idea. So the work, it was started before, as I said, in 2019. So the work, as it's going to be a continental document, it was not driven by the experts like us, but we really want to drive by like the task force members who came from the different countries of the continent. So the work was started, the task force actually inaugurated in 24th of February 2020, and then the composition was subject matter experts from the different corners of Africa, as well as we have also other experts like from US CDC, from the WHO, from Gavi, and also other organizations. So the main objective is to draft a HI policy, which is going to be guideline now, a guideline and standards for the continent. And then the output, as you see this morning, is the final document, which is published this way. I hope Mercy will give you one copy, but you see it this morning. And then now we are very excited that this document is now endorsed by the Africa CDC and then going to be in use across the continent. So just to briefly share the approach, the major approach we use on the development of this was, the first thing was we were reviewing scientific publications and also governmental reports like on the internet as well as on the different countries of like in the continent. And also when we set standards, we review international known comprehensive and then robust data exchange standards, because for some of the standards, we really don't need to reinvent the wheel because they are already matured and available, so we really want to use them. And also, some of the suggestions were also actually like advices and then suggestions from the task force members as leaders in the field. And there is there is one very interesting publication, a review of current evidence on the health information exchange policy and standard on the continent. We do a systematic review, like what's going on, what kind of standards we have, and also what are the challenges. This paper is published on PLOS Digital Health. Probably you can just search it on the internet. You can find this. So this gives us a very comprehensive understanding of the current landscape, so that we can start developing the major document. So once we have the task force members, which were like we are meeting bi-weekly in developing the document, then we have validation workshop across Africa in 5 regions. That was really a massive work which happened for the last years. And then as you can see from this picture on the top, like everyone was with mask like during that time, because most of the work was ongoing during COVID time. And then across the 5 member states, we have more than 100 experts who participated from all member states. And then all relevant feedbacks from the member states were incorporated into the document. And also, I will talk about that. We also established a committee of practice, which are like those members of those validation working group will be the members. So the final version, as I showed you, we have the paper version as well as the final version will be published on the Africa CDC website. So in terms of content, I will really not go in detail because it's already validated and endorsed, but like to show you what's included. The first section is the policy, like which mean by the guideline. The idea is like how we are going to share data, the frequency, and then those are the contents. The standards, more of technical, whenever we develop a system, what are the different standards which are recommended. And then section C, we have an implementation framework, as well as we have annex documents. So on the policy, if you go through the document, we have the governance, like which means that how data is going to be governed across the continent, and then whenever data is coming from member states to Africa CDC, what are the mandates Africa CDC can do? And then if there is going to be a data breach, what are like obligations that should happen across the member states as well as Africa CDC? Those kind of aspects are highlighted in the governance. And then the second portion, the second section is the continental data exchange architecture, reporting, and then sharing, how sharing can happen, like how frequent sharing can happen, especially, for example, during COVID. Some of the countries were reporting like every day. Some countries were reporting like every week. So what kind of standard reporting mechanism we should have, especially at the time of pandemic, was also highlighted in this section. And then the other section is the data ownership and then use agreement, like who owns the data, how we are going to use those data, and also what are the obligations in using data. That's also highlighted in this section. And then the fifth one is open data. As we know, like open data is data which is totally open. Disaggregated data, we call it open. So when like data is going to become open data, what are the agreements? Especially when you think of open data for health, it's very sensitive. So when that data is coming open data, it's like in detail highlighted in this guideline document. And then the final section on this is the data privacy and then security policies. Here also in detail we highlighted like what kind of EU conventions we have, what are the national laws, what are the mechanisms to ensure data confidentiality, integrity, availability, and as I say, if there is some data breach, what are the things which must be done by Africa CDC as well as member states is highlighted in this section. And then the second section is the standard section. So in the standard, can you put the display, please? So in the, here is a policy on the standard section. I think, as I said, it's more of technical. This is how data is coming to the continent, as well as how data is going to be exchanged between countries. So the first one is, like, if you think of system standards for communication, like we endorsed the HL7 protocol as a standard for the continent, and then messaging standard, vocabulary standards, integration profile. Those are the technical standards. And then most of the standards which are recommended here, they, as I said previously, they are not something new, but we just adopted the global standard. For example, for the clinical data, we could say the latest version of ICD is something recommended, which is also the global standard which is being used. And then for privacy and then the security, we have the external assessment, risk assessment, and also the security standard, which is also a global standard. For the common foundation standards, we have how we are going to, like, standards are managed, and for example, how we are going to recommend the latest standards are being used. Messaging exchange standards, protocol, and then service for interoperability. Those are which are highlighted within the standards framework. And then the final section is the implementation framework. On the implementation, the task force in detail highlighted how this document is going to be implemented across the continent. So in this, like, around 5 areas were highlighted on the document. This is a long content, if you can see through the document. The first is how we are going to develop infrastructure across Africa. For example, if you are thinking of having a big data analytics platform on the continent, how data is coming across the 55 member states, and then what kind of infrastructure is needed, and then what kind of support Africa CDC can provide, and then what kind of advice member states can receive from Africa CDC. This is highlighted in this section. And then the other one is investment. How, like different investors can invest in digital health, especially in terms of public-private partnerships, the approach, and then what can be done. It's highlighted on the investment section. And then the other one is the mentoring and evaluation, how progress is monitored and evaluated. This is also highlighted on the section. The fourth one is the research aspect as well, how, like, research and learning and dissemination can happen. That's highlighted on the research section of this document. And then the last one is how, like, Africa CDC can build the informatics capacity across member states. That was also highlighted in this section. Here I really want to highlight one of the recommendation. I think the task force was having, like in the US CDC, there is a program, the Public Health Informatics Fellowship Program. The task force members were recommending having a similar program within Africa CDC, so that, like, different experts from member states in informatics and other sections, they can come over and then get, like, training in informatics, so that it's a kind of, like, on-job training, so that they can have a practical lesson. I think there is some progress with this, so we are glad to hear that, as that was a recommendation from the task force members. So, moving forward, what are the next steps? So, among the work, the next steps are, the first thing, which is the major needed one, is data sharing agreement between member states and Africa CDC. Like when you think of data sharing, it's like what is expected from the member state as well as from Africa CDC. So I think we have drafted the document, like what's needed, what kind of data sharing agreements is needed. The document is drafted. I think this needs to be practical on the ground, the data sharing agreement between Africa CDC and then the member states. I think that is the next major step which needs to be done. And then the other one is we have the HI Committee of Practice. As highlighted previously, we think of the HI Committee of Practice as like members who are participating in the validation workshop. Like across the 5, we have more than 100 members from the 55 countries who are participating in this. So they are now the members of the HI Committee of Practice, as well as additionally, we want also others to join so that we can have that strong community. But we have to run that committee of practice. That is the next work we need to do. And then the third one is like we really need to do a community, like a maturity assessment. I think the previous presenter was doing a great presentation about maturity assessment for EBS. I think even for HIE as well as totally for the digital health, we need to do a maturity assessment of what is the status of digital health across different member states. We know some of the countries within Africa have like advanced digital health capacity, but some are still in infancy. So we really need to do that maturity assessment to see like where is the status, and then we can develop a tailored intervention plan and also support within Africa CDC. So for this, we have started the work of doing the maturity assessment. In doing this, we are thinking of using a framework to assess countries, like in terms of leadership and governance, like where are they, like what kind of strategies they have, what kind of investments they have, the policy, the leadership and governance. The second domain is the management and then the workforce, what kind of capacity there, and also what kind of financial investments in digital health are happening. And also in terms of standard and also interoperability, we really want to see like what is being practiced in terms of standard, the core services, the current data exchange mechanisms, and also in terms of ICT infrastructure, what do we have like for the network, for the business continuity, and also for operations and then maintenance, what are the things happening in member states. We really want to do that kind of maturity assessment so that once we finalize this, it will help the future investment directions. I think currently we are developing like a detailed questions for this. Probably we'll have like the email list. So Africa CDC colleagues will share you like a follow-up questionnaire. We'll be glad if you can fill and then send us back. We'll finalize the maturity assessment. So saying this, I think like now having this comprehensive national like continental data exchange standard and policy will help us that grand vision of having real-time data exchange for immediate response at the time of pandemics. So I really want to finalize by just saying this: the CHI task force members finally on our final meeting, they say that we envision the health information exchange guideline will standardize data exchange across the 55 member states of the continent, where everyone in the continent benefit fully and immediately from digital health investments. That was a final statement from the task force members. So, saying this, I really want to say thank you so much for Africa CDC for the opportunity given to us being on this work, HISP South Africa, and also our university, Gondar University, all the task force members, as well as our technical experts. In doing this, our task force members, I'm not sure if you can read it, but all those 32 members were experts who contributed for the development of this document, which is very, very, very important for the continent. I think those were the members. I really request all of you to give one round of applause for the task force members. Thank you so much. If you have any questions, feel free to drop me an email here. This is my email. Thank you so much. Have a good day.
Thank you. Thank you so much, Dr. Binyam, for that very detailed presentation. And I believe we'll have some live questions for you after our next presentation. Online, she's joining us remotely, is Emily Atuhire, and she is the Africa CDC Mortality Surveillance Coordinator. I hope you can hear me, Emily. We just need to see you on the screen. And she'll be taking us through Africa CDC's mortality surveillance training modules over the next 15 minutes or so. And then we'll have a quick Q&A session for another 15 minutes. Is she online? I know she was standing by. Okay, let's give it a second.
Can you hear me? Please confirm if you can hear me well.
Yes, we can hear you, but we need to see you as well. Can we also get her audio up a bit? We can see your presentation, Emily.
Can you see me?
We can see your presentation, but we just need to get her audio a bit higher so she's more audible. Okay, Emily, we can just have you say something. We can see you now. Great. And tech team, if we can get the audio up a bit higher. Okay, Emily, if you can count to 10 so we can get your audio levels.
Can I go ahead?
Count to 10. We just need to get your audio levels a bit higher. I don't think she can hear me. Tech team, can we get her a bit louder? Yep, we're still having a bit of a technical issue with her sound. While we're waiting for that, I think we can go to, can we try once more? Let's try once more. Emily, can you give us just a sound bite so we can get your audio levels?
Okay, thank you.
She's still quite low. Okay, while we are trying to get her online audibly, do we have any questions? Any questions for the past two presenters or reflections? Okay, we have a hand in the corner. Please go ahead.
Can you hear me?
Yes, yes, go ahead.
I have a question. My questions are really to Dr. Binyam and his very good presentation on health info exchange. People tend to do what they were taught in the university. If you come out of a public health school, you come out with a set of tools and you apply them. So if you have 5 people working in 5 countries that came from 5 different universities, they may very well have completely different concepts of what the format should be for data and how those data should be treated. So what is the role of universities, medical schools, and schools of public health in the work that you're doing with the task force? Thank you.
Thank you very much. Any more questions, comments before we field that to Dr. Binyam? Going once, going twice. Yes, Sarah, go ahead. You're not audible. Do you have a mic on your table? In French. You get the mic.
Bien, merci tout le monde. Je vais parler en français parce que mon anglais n'est pas allé trop loin. Moi, c'est Dr Zabré de Burkina Faso. Je suis là au compte donc du CDC Africa, mais aussi je viens d'un institut de santé, Institut national de santé publique du Burkina Faso. Malheureusement, le directeur a raté son vol, il n'a pas pu venir. Voilà. J'ai suivi avec attention donc les panélistes qui étaient là et j'ai compris le rôle effectivement que les instituts donc de santé peuvent jouer dans le cadre donc de la surveillance basée donc sur les événements. Et aussi, c'est quelque chose que nous vivons là-bas tous les jours. Parce qu'effectivement, il faut pouvoir convaincre au niveau supérieur, donc au niveau donc, du gouvernement, mais aussi être opérationnel pour pouvoir avoir donc, des actions concrètes, prouver à ces gens effectivement qu'on est efficace et avoir aussi une bonne assise communautaire. Donc du coup, avec la présentation donc, qui vient de passer sur l'échange donc, des données, ça me fait réfléchir à ces choses. Ça veut dire comment nous pouvons utiliser les ressources que nous avons déjà. Ça veut dire en amont, l'Union africaine pourrait déjà faire quelque chose au niveau des États pour les amener donc, à adhérer davantage à l'échange donc, des données. Et ensuite, au niveau des gouvernements, comment nous pouvons utiliser un bon argumentaire des policy makers, donc un bon argumentaire avec donc, un dialogue politique pour amener les politiciens, les gouvernements à utiliser nos données, à savoir que effectivement nos institutions donc, nationales de santé publique sont efficaces. Voilà. C'est vrai que Covid-19 a été une opportunité, mais pas vraiment une opportunité parce que c'était un problème de santé, c'est ça. Mais même en dehors de ça, comment on peut traduire ce que nous trouvons comme résultat à un langage donc, politique que ces gens peuvent utiliser pour pouvoir changer un peu le fondement et adhérer à la surveillance basée sur les événements et l'échange des données. Ça, c'est à un niveau un peu en amont. Voilà. Mais si on parle au niveau communautaire, les bénéficiaires, qui sont donc les populations, on dit souvent que la population est ignorante, mais vraiment, quand il y a la mort, les gens savent qu'il y a quand même quelque chose qui ne va pas. Comment nous pouvons aussi agir au niveau des communautés pour amener ces communautés à supporter les décisions, parce que nos décideurs là, viennent des communautés aussi. Chacun a son petit village, a sa famille quelque part. Comment nous pouvons agir à ce niveau aussi pour que ce soit le même langage dans toute la chaîne. Voilà un peu les réflexions qui me viennent en tête. Et je m'excuse si j'ai dit quelque chose qui n'est pas correct parce que je suis vraiment nouveau au niveau du CDC Africa. Mais ce sont vraiment donc, le vécu donc, de tous les jours. Aussi, une idée, c'est que les instituts nationaux de santé publique ne sont pas encore mis en place dans tous les pays. Il y a d'autres pays qui viennent pour chercher l'expérience chez nous. On les accompagne. Mais avant même que ça n'arrive, quelles sont les structures donc, qui jouent leur rôle présentement et comment on peut agir chez ces gens pourrait aussi rentrer dans le cadre de nos réflexions. Voilà un peu un ensemble d'idées. Je vous remercie.
Thank you very much. We'll take one more before we have the response to Dr. Benya. Reflection, question? All right. So Dr. Benyam, we'll have you come respond to your question.
Thank you so much. So I think the first question was on the role of universities in the implementation of the HIE. I think that's a very interesting question. So I really want to share my personal experience. When we think of universities, I always say embeddedness is very important. For example, even though I'm a professor at a university and also doing research, I call myself an embedded researcher, which means that I always work with policymakers and also on-ground implementers. Whenever they have a challenge, we really go on the ground together. We do basic research, basic operational research. We identify their challenge, and then we develop a solution together with those implementers. So, today and then yesterday, I was hearing there are different challenges, especially in the implementation of EBS on the ground. And then most of the challenge was actually capacity and also the lack of resources in terms of capacitated staff members. I think for the member states, if you really can closely work with a university around you, that will be a winning point. For example, as an example in Ethiopia, for example, we really closely work with Ethiopian Ministry of Health on the ground. Whenever they have a challenge, we support them, we train them, so that embedded approach is something to give a capacity for staff members. And also the work we do, it can be as well evidence informed. So when you come to the HIE, I think the health information exchange, I think it needs three things. The first thing, it needs commitment to implement it, because we have to share data, and then that data, whenever we share, that's going to be important for the continent, And then that kind of commitment within member states, as well as the capacity of Africa CDC to use that data for real-time decision-making is very important. So that biodirectional thing is very, very important. The second thing is whenever we implement, as I said previously in my presentation, I was just saying, like, for example, if you take the standard, they are very technical, right? So whenever you develop a system, it can be an EMR system in the hospital, or it can be a data analytics platform at the national level. So whenever you do those kind of data analytics platforms, we really have to use those recommended standards by the union. So that, for example, in Kenya, if they are going to use, for example, for communication protocol, if they are going to use HL7, for clinical data, if they are going to use the latest version of ICD-11, and then whenever we develop a system in Ethiopia as well, if we are using that standard, and then if we are going to have some reported data on our border, we can aggregate that data, and then we can get that like East African level aggregated information for real-time action making. So that's why we really want to have that standard as well as that format, so that it can be useful for real-time decision making. So for that, I think universities across us, they will be committed in supporting, because for the HIE, it needs like advanced level of skill as well as a follow-up learning in terms of evidence generation, so that universities can support you in this aspect. I really want to say that. And then on the second one, if I really understand well, like the question was how can the use of the resources and then the exchange of data within Africa CDC and then member states can happen, and also what's expected, if I catch it correctly. I think like the expectation from the member states is, the first thing is like having our systems, if we can have like a standardized developer systems across the continent, that's a certain point. And then I think one of the recommendations I was having on the next step is to have a data sharing agreement between Africa CDC as well as each member state. The task force was recommending that because like we know that data is always sensitive. Once I remember I was just talking with our minister before for years, and then we're saying, oh, we are going to deploy, like the local server is not working more, so why not we use a cloud for the DHIS data? And then like there was a question, no, the cloud is not secure, right? But if you ask a technical person, he will say, even though it's a cloud, there is a way to secure it, right? So those kind of supports, and then what kind of technology we need to use, that really is very important. So in terms of the member states, in terms of Africa CDC, I think keeping privacy and also using the data that is shared from the member state to Africa CDC, it should be like based on agreements, as well as based on specific data use agreements. That's why we also recommend that the like data sharing agreement, so that finally when you analyze that data and then use it, it will be for shared purpose. So I think like having that data sharing agreement will be important, and I think with all the member states, and then if all that data is coming to the continent, I think like the vision of creating safer Africa, as highlighted by the Director General this morning, can be achieved. Those are the points I have, if I don't miss anything. Thank you so much.
Thank you so much, Dr. Binyam. I believe Emily is online now, so we can test her signal once more. Emily, I hope you can hear us. We just need to get you up on screen. That's certainly not what we wanted to see on the screen. I hope she can hear us now. All right, just to manage time, do we have one more question? Comment? Fantastic. Trying Emily once more. It seems technology is not on her side. If not, we'll have to move on to our closing remarks. So, Dr. Benjamin, who is the head of policy and health diplomacy, will take us through a few closing remarks as we move on with the rest of the program. We'll also have the regional side meetings, much like we did yesterday. I'll give direction on how we will split those groupings up. But for now, unfortunately, we haven't been able to get to Emily. We'll move on to our closing remarks from Dr. Benjamin. Before then, however, Dr. Wari, I hope you are ready. We'll do a continental community of practice for 15 minutes, and then we'll go to our closing remarks. Thank you.
Thank you. If I can have the presentation. Okay, thank you very much. Good evening once again. As we come to the close of this event, I would be giving a brief presentation on the terms of reference for the Continental Community of Practice for EBS. As we know, we have regional communities of practice in some of the regions, and we've had the presentations from Zambia, Tunisia, so Zambia for the southern region and Tunisia for the Northern Africa region. We also have this community of practice in the central region. So the Continental Community of Practice is the consolidated community for all the regional communities of practice. And in July last year, here in Nairobi, we had the EBS Framework Validation Workshop, where this framework was revised. And here we see the team that revised the framework and the team that put together the terms of reference for the Continental Community of Practice. And I can see from the picture, you can see some of the colleagues in the room from EXA, WHO Afro, member states, Zambia, NCDC, Nigeria CDC, and some other Resolve to Save Lives. We had 31 participants, and they came together to put, to create the terms of reference for the Continental Community of Practice, and this was adopted during that meeting. So I'll just go through the terms of reference briefly, and what the community of practice intends to do is to share best practices, including around the event management system, experiences and challenges, and how these were resolved. Another thing is to share the operational tools and plans, such as resource plans, strategic plans, work plans, and case definitions amongst that. And one of the chapters in the revised framework is on monitoring and evaluation. So one of the things we're highlighting here is that the community of practice at the continental level would be sharing monitoring and evaluation tools and practices around M&E. With regard to the frequency of meetings, we agreed that the community of practice will have regular virtual meetings, and this will be held quarterly, and there will be an in-person meeting once a year. And this meeting will be an annual conference where we can share publications, discuss on the implementation of event-based surveillance in member states, on the continent, and also globally. So we also discussed about sharing relevant opportunities, including funding opportunities for research and training on event-based surveillance on the continent. As we expand and implement EBS in member states, we realize that we're having more experts on event-based surveillance. So we agreed that we would establish a network or a pool of experts within member states, so that we can have exchange across the continent. So we can have member states, experts from member states going to other member states to strengthen event-based surveillance within the member states on the continent. And then an e-learning platform is currently being created by Africa CDC, and we want to do this so that before we go to implement EBS in member states, we would people have a baseline or some knowledge about EBS prior to before the training itself. And finally, we were looking at this community of practice. We're looking at having exchange visits between member states and also between partner organizations. And within member states, we want to ensure a buy-in for EBS at the high level. I want to also state that this strategy was put together by Africa CDC, the member states, and experts to strengthen the implementation of EBS on the continent, as we have also seen the success stories from at the continental level, like as presented by Dr. Sua from the northern region and Dr. Davy from the Southern Africa region. And so with these regional communities of practice will come together and meet at a higher level quarterly online and once a year to see how we can expand and improve and strengthen event-based surveillance on the continent. So these are the terms of reference for the continental community of practice, and I would hand over to Mercy to take the next step on this as we call on some colleagues to speak about this. Thank you.
Good afternoon, colleagues. Good afternoon, esteemed guests. So thank you so much, Wari, for setting the stage. As Wari has presented, this is a long journey. It didn't just start here. We have all been a part of this since the inception last year that we convened in Nairobi. I don't know why Nairobi is so sweet for everyone to keep coming here, but thank you all for coming, and we are looking forward to this huge milestone as a continent. So we have some regional economic communities here, and they will also be providing a statement to support this initiative or to still anchor on what we just presented. And I'm going to be calling Dr. Ludovic Tamandia from the Economic Community of Central African States. Dr. Ludovic. Thank you. I'm also going to be calling on Professor Yosa from EXA. And you know, when you see two gentlemen, you're expecting a lady, right? You're right. So I'm calling on Dr. Henriette from IGAD. Dr. Wari has presented on the community of practice and terms of reference. As a regional economic community, we know your role is critical in ensuring that the member states within your regions actually are part of this community. But not to put words in your mouth, we want to hear what your thoughts are with regards to the establishment of this community of practice. So I will start with Dr. Henriette.
Thank you, Mercy and African CDC, for all the work that has gone in strengthening public health systems and institutes across the continent. I'm privileged to be here. Dr. Harriet Nabkwas, a regional disease surveillance expert at the IGAD Secretariat in Djibouti. I know, may not know about IGAD, but IGAD is a REC, and we have 8 member states in the Horn of Africa, Greater Horn of Africa. As I sit here, I just want to say that it's a great initiative that African CDC is putting in place for us to have a community of practice that is going to further what we have just launched today. We have learned from all the presentations that some member states actually started event-based surveillance way earlier than others. So noting that we are at different stages of implementation, I think this community of practice comes in really handy for us to be able to share our lessons, to share our challenges, And it gives us a forum for discussion so that we can come up with solutions in real time as we discuss. And I think this is also going to be a great platform, as presented in the TOR, of experts that African CDC can actually get back to support them in rolling out this event-based surveillance across the regions, since the member states at different levels. So I will also be a champion of event-based surveillance in the Greater Horn of Africa. We will talk about event-based surveillance so that it is surely rolled out, because it's the way to go. Thank you.
Thank you so much, Dr. Harriet. One key thing coming out, we want to ensure that this happens so that we can share our challenges as well as our success stories to also inform decision-making on the continent, in your region. So thank you so much, Dr. Harriet. So I would like to pass on the mic to Dr. Ludovic. Thank you.
I'm going to give my remarks in French. Merci beaucoup pour la parole et pour l'initiative à laquelle les communautés économiques et régionales sont conviées. Pour nous, pour la communauté économique des États de l'Afrique centrale, dans le cadre de justement l'appui à la mise en place ou au fonctionnement de la communauté des pratiques pour la surveillance basée sur les événements, je peux dire que le thème de référence rentre très bien dans le cadre de ce qui est déjà fait au niveau de la communauté. La CEAC a un plan stratégique qui accorde une place prioritaire à la santé pour la période 2020-2025 et justement qui vise justement à renforcer les systèmes de santé justement en vue de renforcer l'accès aux soins de santé de base dans le cadre de la couverture sanitaire universelle et pour le renforcement de la surveillance collaborative des maladies. Et dans ce cadre, avec le bureau du RCC, du CDC Africa, basé à Libreville, justement, nous collaborons ensemble, nous travaillons ensemble sur des thématiques relatives à la surveillance des maladies. Et donc, nous tenons des réunions, même si le rythme des réunions n'est pas complètement régulièrement organisé. Nous tenons des réunions dans le cadre de la synergie que nous voulons, puisque personnellement, je suis le coordonnateur du projet de renforcement des systèmes de surveillance des maladies en Afrique centrale, qu'on appelle le REDIC 4. Je suis le coordonnateur régional. Et cela permet à notre bureau, au niveau de la CAC, et le Centre collaborateur régional d'Afrique CDC, justement, de nous réunir régulièrement dans le cadre de la synergie. Et donc, cette question, par rapport au thème de référence, avec la problématique du partage des informations, d'échange d'informations de santé, la production de bulletins épidémiologiques et beaucoup d'autres thématiques, nous l'abordons ensemble avec CDC Africa. Et donc, dans le cadre justement de cette synergie, nous avons un plan de travail avec RCC que nous sommes en train de dérouler. Et donc, ce plan de travail, justement, prévoit des appuis et des partages d'informations, des ressources aussi, que nous mettons aussi à disposition pour pouvoir fournir un appui technique au pays. Voilà, et je crois que ce cadre mérite d'être encore renforcé, d'être mieux organisé à travers tous les outils qui ont été produits ici, qui seront vulgarisés, disséminés au niveau des pays. Cela nous permettra de renforcer justement ce qui est déjà en place, qui a déjà bien commencé et qui devrait être pérennisé. C'est ce que je peux dire par rapport à cette collaboration dans le cadre de la mise en place le fonctionnement de la communauté de pratique pour la surveillance basée sur les événements en Afrique centrale.
Thank you so much, Dr. Ludovic. And again, there definitely has to be that synergy. We already see that some of this work that we are advancing is already part of your priority initiatives as a regional economic community. Thank you so much for that. So over to you, Dr. Yosa.
Thank you very much. Thank you very much, Mercy. Once again, congratulations to the Africa CDC for a wonderful milestone achieved. On behalf of the East Central Southern Africa Health Community, mine is to indicate our unwavering support for the initiative, and in so saying, is based on two major reasons. The first, that this advances the principle of the African peer review mechanism that has been endorsed by our heads of state. So by bringing together experts in the field to share knowledge and help each other improve, we are actually speaking the same language as our heads of state speak when they talk about the Africa peer review mechanism. So in my understanding as a professional, this is one way we can give meaning to that overarching principle of the Africa Union in which the Africa CDC is embedded. Secondly, EXA Health Community has been a part of the process of developing the TORs up to the point where we are. And we are, as my sister and my brother have already indicated, keenly aware that we are at different stages of development. We have different capacities, we have different experiences, and the more we are able to bring those discrete resources and experiences together, the better we shall achieve the ultimate aim of ensuring the global health security for our region. So an unreserved support for the initiative from EXA Health Community, and all the best to Africa CDC and the entire Africa Union as we take these initiatives ahead. Thank you very much.
Thank you so much, Professor Yosa. And I'm happy that we have all the member states that you have been supporting us for in the room. And as we can see, we have such an enormous buy-in and support from all the different regs. And I hope that the member states are also excited to have and welcome this new baby to the continent. So thank you again. A round of applause for them again. Thank you. I'm now going to call on Dr. Yenyu to give the final word with regards to the establishment. Please, you can take your seat kindly. I'm going to call on Dr. Yenyu now to give the final word on the establishment of this continental community of practice. Dr. Yenyu.
Thank you, Mercy. So I will echo is what the previous presenters reflected as to the importance of this community of practice, which really is an important forum to share resources, technical guidance, any new developments, sharing data, and also looking into what really other countries are doing. So one strong community of practice program that I know in public health is a community of practice on HIV viral load and early infant diagnosis. That program has been running for, I think, more than 7 years, continuously without interruption. What they do is, they have a regular virtual session periodically, and then annually they have a face-to-face meeting. And I had the opportunity to attend 2 of those face-to-face meetings. It has been really very enlightening. And the level of information that's coming through that forum is really, very, very important. New guidelines, treatment options, any change in terms of drug regimens, laboratory methodologies, and so on. It has been really very, very helpful. So, we said yesterday and today that our surveillance modality has to change. Because the usual practice, collecting the information from patient records, health facilities, aggregating that one at Ministry of Health and having that report is not enough. That's what we said. Because of the changing environment, we need to adapt also to that change. So our surveillance program has to go beyond. That's why we were emphasizing really the implementation of EBS as an additional source of information for our early warning system, triangulating and collecting data from different sources, and so on. So which means that as we continue implementing this complex program, I'm sure there will be lots of questions that will come from member states, and at times you really wonder where can you get that information. So if you have really a group of experts coming together as a community of practice regularly, and then you can pose your question and ask, and you can get those resources easily. And then it's also an important mechanism to create professional network. These are professional meetings. These are technical experts coming together and discussing on a common issue, a common purpose, that's strengthening event-based surveillance. So we thought that this will be a very important forum for the continent. So our role as Africa CDC will be, we continue supporting and creating a forum for such type of communication among the different experts. We found it to be very useful during COVID-19, and in laboratory practice we have used it. Even reading the outputs of the equipment remotely circulating through the experts has been really very helpful. So I feel that it will be a very important forum for all of you. So as of today, we will say that the Continental Committee of Practice on Event-Based Surveillance will go live, and in terms of subsequent meetings and the format of the meeting and so on, who will be attending, so we will communicate subsequently. So thank you again. This has been really very helpful. We appreciate all your contribution. And as Africa CDC, as I said, we share our responsibility, and we are committed to really support this process. I thank you.
Thank you, Dr. Yenyu. So just to reiterate again, I don't know if we all got it right. From today going forward, the community of practice is live. And for those, our colleagues or our regional experts that have not been part of this, kindly just indicate we had already taken your contacts for the most part. If our regional analysts have not contacted you yet, please let us know. And again, today we are going to be meeting in our regional groups just so that we get more insights, because it's going to be like the umbrella of all the different regional communities that already do exist. So kindly feel free to reach out to anyone having this, this bowl, so that they can also help you. That's all our colleagues that are working within the epidemic intelligence team, and they would be able to guide you accordingly. So I'm going to hand over to our moderator, Victoria, to continue leading the remaining half of this session.
Thank you, Mercy. We're actually a little over the half of the session. I think we're into the last 10% of the session. I'd like to invite Dr. Benjamin, Head of Policy and Health Diplomacy at Africa CDC, to make some closing remarks as we close out the session, and I'll be back with more on the regional committee meetings.
Thank you, moderator. I'm just told to close, so it is closed. No, thank you very much. Let me just say all protocol observed because, at the risk of starting naming, you may forget very important people, players in the room. So all protocol observed. As we come to the end of the official launch of the EBS resources, I would like to take a moment to express our gratitude on behalf of Africa CDC to all of those who have made these 2 days possible. The EBS has been painstakingly developed to meet the ever-increasing need for high-quality surveillance solutions in today's fast-paced world. We must recognize the commitment and dedication of our team behind EBS, and as Mercy said, they have all the big bow ties there, led by Dr. Yono, who have put in tireless effort to bring these resources to life. We also owe a debt of gratitude to our partners and stakeholders who have supported us in all our endeavors. With EBS, we are poised to usher in a new era of intelligent and proactive surveillance, enabling us to identify and mitigate potential threats before they become incidents. We firmly believe that this system will transform the way we approach health security, making communities safer and more secured. We thank you all for being part of our journey and invite you to join us in leveraging the power of EBS for a safer and more secure future for this continent. I would also want to thank our interpreters, all those who have been facilitating the work, the hotel, at the kitchen there, everybody, who have supported us during these last 2 days. So I wish you all a safe trip back to your respective countries. And I declare close this official launch of the event-based surveillance resources. Thank you very much.
It's closed. Thank you so much, Dr. Benjamin. Almost got scared when you said it's closed. That's the shortest closing remarks I've ever heard, but thank you so much. We're about to move into the regional committee meetings. Okay, so I understand there were notebooks that were passed around. We want to take a photo of everyone. So if you have a notebook with you, hold it up. The framework book, I beg your pardon. The framework notebook, if you have that in your possession. Anyone with the framework book? I think that will do. Were they passed out? Okay, so some participants do not have them. We'll try to get them over to you. Meanwhile, let me take you through the regional committee meetings and how they're segmented. Much like yesterday, we'll split the room into 5. The Eastern region will be back left, Western region stage left, Northern region will be back right, and Southern region will be stage right next to the stage. And then of course, the Central region will be right at the center. But for me, as your moderator, it's been an absolute pleasure and honor being here the last 2 days. I think I can call myself an honorary epidemiologist at this point. I've learned so much and a newfound respect for the Africa CDC, for the National Public Health Institutes, for the member states who are trying to get ahead of disease outbreaks and essentially keep populations safe. I want to say thank you. Can we give us a huge round of applause for your time, for your insights, for your patience as well. I can see the framework notebooks are making their way in. So we want to have a nice moment to remember the last 2 days and also give us some impetus as we move forward to get this EBS framework implemented, as Dr. Ogwell had said earlier, in all 55 member states by the end of this year. A very ambitious target, but hopefully it is achieved. Fantastic. So I have a hand up there. Yes, please, go ahead.
If the interpreters could please translate what I say, I suggest we have a round of applause for the interpreters who have helped out so much.
Absolutely. Absolutely. Thank you so much. Oftentimes behind the scenes, but they've been doing an amazing job the last 2 days. Hardly any breaks when you think about it, interpreting what the presenters and the panelists have been saying throughout. So thank you so much once again to the interpreters for their very hard work. So we're getting the framework books to everyone so we can get that photo. Photographers, if we can come to the front so we can capture that photo well. Great. Keep your hand up if you don't have the booklet yet. And someone from the Africa CDC team will get it over to you. Great. We have some being distributed to the other tables as well. So this is a mix of the framework booklets, I beg your pardon, that we're getting to everyone as we set up for this photo. Photographers, kindly make your way center stage as we get this photo in. Fantastic. Does everyone have one by now? Looks like we do. Oh, we need one in the corner. The gentleman who's raised his hand. Fantastic. I think we can raise the booklets up now in the interest of time. So we can capture this photo, photographers, right in the front, so we can capture this moment. Great. Fantastic. Are we good? All right, so let's try to get this photo captured in the next 10 seconds. I'll count down. In 10, 9, 8, looks beautiful. 7, 6, 5, the rush for the notebooks. 4, 3, 2, 1. Fantastic, looks absolutely amazing, amazing. Thank you so much for indulging us. And that officially closes out this workshop. One more round of applause. Thank you. A quick reminder, the regional committee meetings, Eastern back left, Western stage left, Northern back right, Southern stage right, and Central right in the middle of the room. Have a lovely evening. Thank you so much.
Africa CDC has an enormous role in the development of event-based surveillance in Zambia.
We, as Uganda Ministry of Health, the Emergency Operations Center particularly, we have really benefited from Africa CDC's efforts in event-based surveillance, giving us the framework and training us. Before 2022, Uganda was conducting event-based surveillance activities very well, but with the little knowledge that we had, we did not have any training, no framework, so we just hit and run. You say, okay, event-based surveillance, and then we start. Then came 2022 when we had formal engagement with the African Union, particularly Africa CDC. This is when we reached out to the head of the EBS unit in Addis, and she accepted to come over and train us formally on how to conduct event-based surveillance in the country.
Using the EBS as some of the documents we've used to adapt our work towards implementation of event-based surveillance in the country. We are now at a stage where we've developed the guidelines for Zambia, and Africa CDC has been very, very prominent in the offering technical support in the development of the same guide for Zambia.
During that workshop, we had what we call the event management system demonstrated to us. And we said, oh, On part of our EBS activities, I think we need that system. Then Africa CDC was happy to say, can we talk? Can we develop a concept? Can we see who is the player? Then we identified the players, okay? In the Ministry of Health, we had to have the Division of Health Information come in. We also had to have some programmers, that HISP Uganda and HISP South Africa, they came over and they started developing the system for us.
The event management system was it's an initiative that we've embraced so well. With support from Africa CDC, we've now trained all the 116 districts in the country, and all the 116 districts now are able to use the EMS system for purposes of reporting the issues of generating reports, assessing risk, and also response. So all the documentation as it relates to management of events from signal detection to response is anchored on the system, and most of the districts are participating in the system.
Health security globally is not complete until every part of this world is safe from outbreaks and disease threats.
There is a framework which Africa CDC has, and they trained us on how to do a hotline EBS, facilitate EBS, facilitate best EBS, how to undertake call center, everything. And then we also had a chance to adopt the material we got from Africa CDC into Ugandan.
In the short period in which the EMS has been deployed in the country, we've seen quite a number of signals and events being posted on the system. COVID-19 has been one of the conditions that has been shared on the system. But other than COVID, we see that we are sharing a lot of information pertaining to vaccine-preventable diseases. In particular, it's the measles events. We've reported quite a number of chickenpox as well. Scabies have been picked up through the same system. But other than these skin conditions, we've seen it going beyond to report issues around bilharzia as some of the events that we are picking up.
The EMS in Uganda is still work in progress though, but we are so excited about what we have already achieved. The EMS has captured so many signals because at the level from community to the triage section where there's a lot of noise. We have levels in Uganda where we do the verification. For example, at national level, I will not go to a district, say Obonji or Kagadi, and I confirm an outbreak. No, there are structures already at the grassroots. There is what we call a district surveillance focal person. Even lower health sub-districts, there are several surveillance focal people. So as we receive it from the national level here, we'll triage it to them and they will confirm. We cannot say as Uganda that we are there yet. We still have some challenges, especially having the programming done to completion. Our event management system is still work in progress. We are still working on it together with our programmers from South Africa and Uganda, plus the local Ministry of Health Division of Health Information. The
implementation of EMS currently is anchored within the Ministry of Health, but our wish is that it needs to have an outlook of One Health surveillance, in the sense that the priority list of signals are not only related to human health, but cut across other sectors to do with animal health, environmental health, and the ecology. So we need partners on board to be part of the process. Other than that, you need huge investment in terms of the information, communication, and technology tools in terms of computers which needs to be deployed for our staff for use. The other aspect is obviously around interoperability of the systems, because the EMS system alone needs to communicate, for example, with epidemic intelligence from open sources. It needs to communicate with the Public Health Emergency Operations Center. So those are some of the challenges we have, but with the support from partners, we should be able to overcome those challenges and make the system even better within the country. Yeah.
Africa is willing, able, and ready to do its part. We are asking you, as our partners, to join us in implementing the new public health order so that we can be able to do things differently, to be able to achieve different and better results.